Breast augmentation is performed to increase the size of the breast and enhance the shape. With over 300,000 cases per year, it is the most common cosmetic surgery performed in the U.S. The implant fill can be silicone gel or saline. All approved implants in the U.S. have a silicone shell. The shell can be textured or smooth. While the precise market share for the different implant types in the U.S. is not known, the panel will be asked to discuss whether the benefit-risk profile for textured and smooth implants are different for specific indications. Breast reconstruction is performed after surgical removal of the breast or for congenital or traumatic deformity. The implant can be placed above or beneath the pectoralis muscle. The implant-based reconstruction is sometimes performed with a temporary tissue expander or placed immediately, so-called direct-to-implant. The procedure is performed with or without surgical mesh. While surgical mesh has not been cleared for breast reconstruction or mastopexy, the panel will be asked to discuss benefits and risks of breast surgical mesh for specific indications, to recommend clinical trial designs, and the level of clinical evidence that should be required for a marketing application that would be acceptable to characterize these indications. Patients have indicated they are not informed that breast implants will likely require reoperation. Breast implants are not lifetime devices. The longer a woman has breast implants, the more likely she is to experience local complications or adverse outcomes. The panel will be asked to discuss what additional steps can be taken to ensure that patients are better informed about the risks of breast implants. Breast implant rupture is one of the most commonly reported events related to breast implants. For silicone implants, rupture may be symptomatic or silent, intracapsular or extracapsular. A review of the core studies will be presented, and the panel will be asked to discuss MRI screening recommendations for breast implant rupture. Breast implant-associated anaplastic large cell lymphoma, also known as BIA-ALCL, has been reported to occur years after implant placement. The real incidence is unknown. However, it has been reported to occur between 1 in 3,000 and 1 in 30,000 patients with breast implants. Current information indicates there are more reports of BIA-ALCL involving textured breast implants than smooth breast implants. However, in 30% of the MDR reports, there is no information regarding implant surface texture at the time of BIA-ALCL diagnosis. Regarding history, there is even less information available. As the denominator for the number of textured and smooth implants is unknown, and both the patient history and the implant history is often unknown, it is undetermined if there are more patients with textured implants versus smooth implants. Due to this missing information, the agency believes that it is important to inform all patients who are contemplating breast implants or who have breast implants of the risks of BIA-ALCL. The panel will be asked to make recommendations regarding next steps for the characterization, incidence, and risk factors of BIA-ALCL. A range of symptoms that some women have attributed to breast implants have included complaints such as memory loss, brain fog, fatigue, joint pain, and rash. MDR analysis data will be presented, and the panel will be asked to discuss methods for assessing and addressing breast implant illness symptoms. Determination of safety and effectiveness involves assessment of benefit risk. At the end of the day, it is the patient who gets to decide what level of benefit risk is acceptable. So we need to provide the patient the information she needs to make an informed decision. The panel will be asked to discuss the role and responsibility of all stakeholders for communicating breast implant-related benefits and risks to patients. And with that, we thank and look forward to our panel for providing their expertise. Now we will hear from breast implant victim advocacy about what patients who have had breast implants think the patient contemplating breast implants should know. Thank you.
Thank you, Dr. Nagel. Next, we'll hear a presentation from Ms. Jamie Cook from the Breast Implant Victim Advocacy. who will speak on what patients who have had breast implants think that patients contemplating breast implants should know. Ms. Cook.
Good morning. My name is Jamie Cook. I traveled here today from Texas. I have no financial conflicts of interest. I'd like to thank Dr. Asher and the panel for inviting me to speak today on behalf of harmed patients. I got PIP breast implants in Dallas in 1998. I remember my doctor telling me about local complications, capsular contracture, rupture, necrosis, etc. That was the extent of the warnings. I was a paramedic and I was active. Within 3 to 4 years, I developed chronic fatigue and autoimmune disease. Other symptoms were swollen lymph nodes, recurrent fever, brain fog, and more. My life was greatly affected by my illness. My doctors told me that nothing could be found to explain my health problems, that I was just a tired mom, and I was getting older. I was 24, so I knew it was not my age. In 2012, my textured saline implant ruptured. I did not have the money to replace or remove it for 3 years. During that period, I developed arm and hand numbness and recurrent migraines. Upon removal in 2015, most of my symptoms went away immediately. I still battle autoimmune disease, but my life is so much better. Several of us founded breast implant victim advocacy to help raise awareness of illness and complications that can arise from both silicone and saline breast implants, including BIA-ALCL. We've now met with the FDA on 3 separate occasions. We work with many other organizations and patient support groups. My story isn't as bad as the stories we hear every single day, and it's not going to be as bad as the ones you will hear today and tomorrow. I don't even feel sometimes like my story is important anymore, because the issue is so much bigger than me. It's so much bigger than even the patients in this room. We just hope to represent the women the way that they deserve. I stand today representing thousands of women. We have quite a few here. I'd like to ask all of the BIA-ALCL patients to just quietly stand. Ladies and gentlemen, these women supposedly represent 1% of this rare disease population. Please listen to them as they share their firsthand experience of what most of you have only read about. Now, if I could ask all the women who have been harmed by breast implants, or those who know someone harmed, to stand. Not all will speak at this meeting, but they come in solidarity today to say enough is enough. Travel was a financial burden for many of them, but being physically present was important. Many are too ill to travel. We speak for them. We are their voices. Thank you. I was asked to try to address what do you believe patients need to know prior to implantation. This is complex, but what I will emphasize is I was not warned. Most ladies we speak to were not warned about most of the risks that we will discuss. There are tens of thousands of women on social media, and many tell us that the manufacturer's pamphlets were never provided. Most women say they were not well informed. What can you do to change that? Breast implants are not lifetime devices. The FDA states that breast implants are not meant to last forever. However, some plastic surgeons say otherwise, as you can see on this website. Many women are told breast implants may last a lifetime. They tell us that newer, more cohesive implants won't rupture because you can cut them in half and nothing will happen. We've even seen videos of doctors running over breast implants with cars to show how strong they are. But the human body is a very different environment, so true informed consent should be clear that repeat surgeries are likely and expensive because the devices don't last forever, some just a few years. This is a 6-year-old Mentor silicone implant on the right with a scar capsule on the left. This patient had 3 different sets and capsular contracture twice. Her list of symptoms was very long. She explanted in 2017 and her health greatly improved. These are 2-year-old Mentor silicone implants, 2 years. How many revision surgeries would she have needed if she hadn't explanted in 2017? maintenance, follow-up, and complications. These data are from the Mentor PMA in March 2005. Allergan statistics are similar. FDA approved breast implants on the basis of these very high complication rates, even in the first 3 years. Are patients made aware of these rates? I don't believe so. This is an example of capsular contracture, which can be extremely painful. These textured silicone implants were just under 3 years old. They show fluid buildup and capsular contracture. Fluid was aspirated and tested. Additional testing was done at the time of explant. The FDA points out that in most cases, neither you nor your surgeon will be able to find evidence of rupture by a physical examination. Breast MRIs are recommended after the first 3 years and then every 2 years from that point on. Many patients tell us they were never told to undergo MRIs to check for rupture. MRIs can cost more than $2,000, and often insurance will not pay for an MRI to check for rupture. Many women undergo mammography to check for rupture instead, but FDA's own research shows that can cause implants to leak. Shouldn't the FDA require studies to determine if sonograms can be a more affordable alternative to MRIs to check for silent rupture? This patient had an ultrasound and 2 MRIs that could not conclude whether she had a rupture. For that reason, she did not get insurance coverage for the removal. It was not until explant surgery that they found the rupture. Health insurance often isn't helpful. Treatment of complications from breast implants is often not covered by health insurance, even if the woman is very sick. This includes removal. Health insurance denial can prevent monitoring or radiological screening. Many women we know in support groups simply cannot afford to remove their breast implants, and insurance will not pay. There was a very large explant assistance fund, but it was so overwhelmed this last year with desperate patients that they quickly ran out of funding. When these women seek help and there is none, they can get desperate. It feels like no one will listen and no one will help. We get emails from women asking if we have any resources to help them. We have to tell these women that they have very few options. These are some of the statements from our women. Chemical transparency. Breast implant materials are secret. Plastic surgeons can tell you if the implant is filled with silicone gel or saline, but they can't elaborate beyond that. We have reached out to the FDA and surgeons over the last few years to ask for an ingredient list, but haven't received one. The FDA wrote the following: ingredients in a device is proprietary information, and only the manufacturer can release that information to the public. Author Gail Hamilton lists ingredients for breast implants from Dow Corning trials in her book, and lists on the internet note ingredients like acetone, formaldehyde, xylene, epoxy resin, and lacquer thinner. Authors Barbara Stanistry and Carlos Mesa describe heavy metal toxicity from platinum in their books. Full recent ingredient lists cannot be found. Cosmetics, food, and cleaning supplies all must be labeled so consumers can make an educated decision about purchasing that product. We have medical devices, however, that do not provide that information. Surgeons can't ensure informed consent if they cannot even tell me what the product they are using is made of. Are certain chemicals also more likely to cause BIA-ALCL? Look at these terrible rashes and irritations of women in our groups. Is there any doubt that this is a bad reaction to their implants? On March 15th, the FDA commissioner put out a statement that finally acknowledges that some women have immune and inflammatory responses to breast implants. He admits that symptoms may not develop until years later, thus the need for long-term studies. His statement also says that the FDA can recall devices that are unsafe, require black box warnings, and require post-market studies. The patients that we represent today point out that the FDA has not upheld its duty to protect the patients. Patients and clinicians have the right to this data so that full information is readily available and so that potential pre-screening and diagnostic processes can be implemented. Symptoms of implant-related illness are not widely recognized. Breast implant illness is one of 22 terms that we have found to describe the exact same symptoms you will hear about today and tomorrow. It is not a medically recognized disease and therefore largely ignored by the medical community. Asia is the only term that currently has diagnostic criteria, and you will hear more about that later in the meeting. Not every woman with implants will develop unwanted symptoms. For those that do, however, it can be devastating physically, emotionally, financially. Some women develop symptoms immediately after augmentation or reconstruction. Others take several years. I have a slide above that mentions quite a few of the most common symptoms that women complain of. Many women with breast implant illness do not realize the symptoms could be caused by their implants. They go from specialist to specialist without any real answers to explain their concerns. They are told they are crazy or made to feel that way and advised to seek psychiatric help. We are ordinary women. We are educated. We are mothers, sisters, wives, and daughters, and we are suffering. Some are ignored and laughed at. Some are suffering financial strain and marital stress. Some are having difficulty raising their children. Many are angry at and feel defeated by a system that has failed them. This could be someone close to you, your family member, or your coworker. I can tell you quite honestly, I never believed this would happen to me. This isn't the life that I pictured for myself. I didn't anticipate spending countless hours educating, advocating for, and listening to women. I didn't plan on working a full-time job that doesn't pay. Neither did many of the women in this room, but we do it. We do it because we don't want another woman to suffer. This collage is just a small representation of the thousands of women who are harmed. Please keep in mind that each of them matters. Doesn't the upcoming generation of women deserve better? These are some of the things that women show us every day. These are examples of ruptures, and these are from women that gave us permission to share. More examples of rashes and skin manifestations. Most of these go away when removed, when the breast implants are removed. These are contaminated implants. The top left shows discolored saline. The second shows contaminants within the implant that look like mold. The bottom shows contamination within the interior of a silicone implant. The far right is debris floating within the saline implant. It was later found to be aspergillus. This is from my dear friend and one of my co-founders. Chandra had a fulfilling and active career that was ruined by her breast implants. The implant at time of removal was not even whole. It's torn and appears to only have a portion of it left. Chandra couldn't make this trip, but she's been a leader to our cause. A Netherlands study in 2014 compared women there to implant patients at Baylor College of Medicine from 30 years earlier. There was no difference in their symptoms. Despite innovation in implant manufacturing, patients were still complaining of the exact same issues. There is, however, a difference in the design of the products. The components have changed. How has this affected the percentage of women harmed by implants? Women who are sick have not been adequately studied. What are our commonalities? Is there a genetic predisposition to disease or a family history of autoimmune disease? Are we seeing an incidence in birth defects to women who have children and are breastfeed while they have implants? We need a comparison of women who are sick with silicone and saline implants to women who have never had an implantable device. We are currently working on a patient-driven registry to address just these issues, and the National Center for Health Research has started a similar project. We need researchers to study the issues that we think are important, not just the questions that the clinicians want to address. Social media awareness. There are over 170 groups and communities devoted to breast implant problems just on Facebook, and multiple websites devoted to the same awareness. The largest Facebook group now has over 70,000 members, and it's growing exponentially every day. Our BIA-ALCL patient group is also growing significantly, with women who are desperately seeking answers. We have a clinician-patient group devoted to bridging the gap between patients diagnosed with BIA-ALCL and doctors. These are women coming together globally with the same concerns and same symptoms. As told by Dr. Edward Melmed, these women didn't just meet in a coffee shop and make this up. The feeling of finding a community where someone understands how you are feeling is indescribable. You've found the piece to your puzzle and you want to shout it from the rooftops. We are a family, we are a support system, we lift each other, we listen when no one else will. It's a worldwide advocacy effort. More needs to be done to ensure patient safety is not being overlooked because of profit. We need the FDA to do more. Preemption. Harmed patients cannot hold manufacturers accountable. Because of a Supreme Court decision, patients who are harmed by Class 3 devices, such as breast implants, can't hold the manufacturers legally accountable. Women who have become victims of breast implants have little to no recourse against dangerous devices because the Supreme Court stated that if the FDA says a PMA is safe, it is safe. Manufacturers have been given nearly absolute immunity. I'm here to point out very clearly today that this is not a litigation-driven movement. We can't seek our day in court. There is no monetary gain for myself or for these women. In fact, most of us end up with financial instability because of our situation. Medical debt, loss of income, disability, with no financial recourse to compensate us for medical expenses, lost wages, or anything else. Women who developed ALCL are offered $7,500 from the implant manufacturer, but that doesn't make up for the thousands on thousands of dollars in medical bills to treat a potentially lethal cancer. The women that are coming forward are sick. They're desperate to return to a healthy state of living. They are not here because of litigation compensation. Flaws in mandated studies. The FDA has required post-approval studies for breast implants as part of their PMA requirements. These studies have been flawed and incomplete and should not be considered reliable. Moreover, the failure of the breast implant manufacturers to complete the PMA required studies provides the FDA the ability to rescind the PMA and basically take away their right to market and sell the implants. Women who were supposed to be a part of these studies were not followed up with or were completely dropped. Some of these women had symptoms that would have been caught in data collection had the studies followed through for the complete 10 years. Some of these women developed lymphoma that would have been documented. We've heard from women who were told that their surgeon was no longer a study participant or told by the manufacturer that the study would not be continued. We've also heard from women who were completely dropped after reporting symptoms. What other data are we missing because these mandated studies were not finished? Here are a couple of statements by women we've heard from. I was enrolled in the 10-year study in September 2009. November 2015, 6 years into the study, I received notification that changes were being made. At this point, all follow-up appointments and questionnaires were ceased. 10-year study, but they blew me off after third year. Year 2, I reported a little bit of fatigue, skin issues, and year 3, the office no longer had a staff member assigned to the study. And year 4, they did not return my calls. Some mandated studies have been terminated. These studies were to look at rare events like lymphoma, cervical cancer, etc. The CDRH sent letters to the manufacturers in 2013 warning of possible revocation of their PMA if studies were not completed. It happened again this month. FDA officials told us in a previous meeting that they had the power to revoke a PMA, but have never done so. If the FDA does not hold the manufacturer accountable, and the legal system does not either, who will? To expand more, we need to look at what is being said by the manufacturers. There is a possibility of risks yet unknown, which in the future could be determined to be associated with breast implants. The study size needed to conclusively rule out a risk of connective tissue disease among women with silicone gel breast implants would need to be very large. It doesn't say it's been ruled out. Literature reports have also been made associating silicone breast implants with various rheumatological signs and symptoms, such as fatigue, exhaustion, joint pain and swelling, muscle pain and cramping, tingling, numbness, weakness, and skin rashes. Studies on the effects of children and breastfeeding has not been done. From the IDEAL pamphlet, the long-term safety and effectiveness of breast implants have not been studied. The IDEAL implant has not been studied for use in breast reconstruction. But do our patients fully understand that these statements are being made? This is my family. I gave birth to all of my children while I had breast implants. I breastfed the first two. My oldest two have birth defects and chronic health conditions. There is a level of guilt that we face as patients, wondering, did my implants play a role in my children's health? The fact is, we don't know, but we need to. Would I have made the same choice knowing what I know now? Absolutely not. I own my decision. I take responsibility for my choice. My choice should have been made, though, with more information. My doctor should have discussed the unknowns in depth. The studies have not been long or large enough to tell us how often a woman gets sick from breast implants. So why are patients being treated as if their conditions and concerns are absurd? Why are women being sent to psychiatrists instead of addressing a potential issue that has yet to be recognized by the medical community? The FDA needs to be more open-minded about what is known and unknown about the risks of implants and to encourage physicians to do the same. Only then will patients be informed of the risks of breast implants. This letter from Mentor to a patient in our community shows how the manufacturer is basically ignoring any accountability. It says, in part, breast implants should not be considered lifetime implants due to the inherent nature of silicone, implant procedures, and potential individual physiological reactions. It says this should be a decision between the physician and the patient. In no event shall Mentor be liable to you or anyone else for any decision made or action taken by you in reliance of such information. Is informed consent thorough enough? We ask surgeons to step up and do what's right. First, do no harm. Help us to hold these manufacturers accountable and demand that they develop a product that is scientifically proven to be safer in long-term trials. Adverse event data is misleading. Manufacturers, physicians, and patients can report adverse symptoms to the FDA. We encourage our women to report directly. Recent scrutiny of safety has brought about concerns over data. From 2002 to 2017, manufacturers were provided exemptions to reporting via medical device report, MDR. These manufacturers instead submitting using the alternative summary report. ASRs are typically submitted on a quarterly basis and can contain dozens to thousands of adverse events in one report. These reports are not transparent to the public. In early 2017, the FDA changed its policy. By July of 2017, the reports that had been previously submitted in ASR began arriving to the FDA in MDR. This allowed the public to have access to the thousands of reports that had previously been unavailable. So from January 2017 to October of 2018, there were at least 17,000 individual MDRs submitted to the FDA, according to Device Events. Prior to this, patients and providers who sought to identify safety data would not have been able to see the true number of adverse events. We keep hearing that our problems went away after the 90s. They never went away. The data wasn't visible to the patients or the doctors. It's deceptive. It's not fair. Risk of cancer. Over the next couple of days, you will have the chance to hear 3-minute speeches from 9 to 10 North American patient advocates. I encourage you to pay attention to each of their unique stories and messages about their journeys of getting diagnosed with BIA-ALCL. We strongly believe that patient real-life experience is paramount to the education and understanding of this emerging disease. That is why it is important to consider a patient representative on your breast implant advisory team. This is BIA-ALCL, breast implant-associated anaplastic large cell lymphoma. The upper left is the typical presentation of swelling. The upper right is an example of a scar capsule mass. The lower right is the aspirated fluid from a breast seroma, the most common presentation. The bottom left is Terry, who you will hear from later. You will hear more about this disease from the women themselves, but I want to mention that we started a patient support group in early 2016. By July, we had 10. Now we have over 160 diagnosed women in the group. These ladies have a clearly defined disease. Most of us don't. The thing is, we all face harm from the same devices. Whether we augment or reconstruct, whether it's implant-related illness or cancer, we wouldn't be here today if it weren't for breast implants. It is our understanding that one of the most paramount obligations you have as an agency is to make sure that the risks of a medical device do not outweigh the benefits. I'm going to highlight some reasons why the number of cases of BIA-ALCL is likely grossly underestimated and why textured implants and expanders should be removed from the U.S. market. A high majority of women who have implants are not aware of BIA-ALCL. Most symptoms, pain, change in shape, are thought to be part of initial complications. The long-standing message that breast implants are the most studied device on the market, so there is presumption that they are safe. Mammograms cannot consistently detect masses within the scar capsule. Often labs and radiologists miss the diagnosis because it is misunderstood and considered rare, and errors are being made. BIA-ALCL cannot be seen during surgery, with the exception of the mass. Often labs and radiologists miss the diagnosis because it is misunderstood. I already read that, I'm sorry. Please take the time to fully understand the obstacles to a BIA-ALCL diagnosis and do not buy in to the dangerous narrative that BIA-ALCL is an extremely rare and easily curable disease without giving such statements the full and robust scrutiny that all women with implants deserve. We do want to thank the FDA for your alert to healthcare providers as a result of our request from our last call to action from our meeting with you in September of 2018. It has helped to increase patient awareness. Breast implant-associated anaplastic large cell lymphoma is a man-made cancer that theoretically can be eradicated by the removal of textured breast implants and expanders from the market. A joint call to action by patients includes the following: mandatory, standardized, informed consent. Mandate that BIA-ALCL and implant-related illness risk be communicated through a patient-surgeon checklist and a black box warning. Request patient representation on the breast implant advisory team. We are asking for 2 representatives, one for reconstructive and one for augmentation. Patients are not being warned, and they need to play a role in decision-making. Compliance from manufacturers reporting confirmed BIA-ALCL cases, and a penalty for noncompliance. We need accountability from the manufacturers. Use your maximum authority towards physicians and institutions to notify patients with textured implants about BIA-ALCL. Although we understand that the FDA regulates medical devices and not physicians, there is a responsibility because it has been approved by your governing body. Therefore, your maximum authority should drive this call to action, and patient advocates are willing to assist with this. Mandate studies for confirmed cases of BIA-ALCL, industry funded, and make it public. There is no current post-market study to monitor the women diagnosed, and recurrence of this disease is being seen in our patient group. Change the incident narrative to emerging. Ban textured implants or request a voluntary moratorium. I don't believe we should remove all implants from the market. That's my personal opinion. Patients do need options, but we do need to be able to offer the patients the safest option available. There are smooth implants and smooth expanders. Does the benefit of textured outweigh the risk? Ask that question of any lady in this room who has BIA-ALCL or a family member who has lost a loved one, and I am sure the answer would be no. Increase transparency in materials used in breast implants. Maintain individual adverse event reporting, and hold the manufacturers accountable for unfinished and flawed studies. If you don't hold them accountable, who will? We again want to thank the FDA for increasing their patient engagement. We appreciate the opportunity to voice our concerns. We want to continue open dialogue and continue to offer our assistance in any way possible. I hope that you face the next 2 days with open ears and hearts. Patients are being harmed. You've heard us, and it's your duty to protect us. Thank you.
Thank you, Ms. Cook. We'll next hear from Dr. Nilsa Loyo-Berrios from the Centers for Device and Radiologic Health, who will discuss the overview of the FDA mandated post-approval studies to date.
Good morning. My name is Nilsa Loyo-Berrios. I'm an epidemiologist by training and currently serve as Deputy Director in the Division of Epidemiology, Office of Surveillance and Biometrics. Today I'm here to provide a high-level overview of the FDA mandated studies for the silicone gel filled breast implants. In 2011, the FDA convened an advisory committee panel to discuss the post-market experience of the 2 silicone gel-filled breast implants that were approved in 2006. At the time, the FDA recognized the large new enrollment cohort studies that were required as condition of approval would not provide sufficient evidence on the long-term performance of these devices due to very low follow-up rates. The panel was asked to discuss study limitations and to provide recommendations on how to better monitor the performance of these devices. The advisory committee meeting was also an opportunity for stakeholders to provide input and their perspectives. The panel recommended changes to the large study data collection tools to make it easier for study participants to complete. They also discussed leveraging safety data from other studies and to use smaller cohort studies for more common endpoints. There's also a recommendation to aggregate data or combined data across manufacturers or devices that use similar technologies. The panel also discussed using well-publicized registries to address rare endpoints, to find ways to establish collaborations between the FDA and stakeholders, to establish a national registry to capture real-world experience and long-term performance. And there was also mention of the need to have an update on the assessment of published peer-reviewed literature. Following the panel recommendations, the large new enrollment cohort studies were redesigned with smaller cohort studies for each manufacturer. These smaller studies are designed to capture performance of the 2006 approved devices, as well as of the most recent silicone gel filled devices that were approved in 2012 and 2013. Each manufacturer is also conducting a large reoperation data collection phase with the study participants that remained in the large cohort study. Through collaborations with professional societies, the FDA, patients, and industry, there are now 2 national registries collecting breast implant data. The Profile Registry collects data on BIA-ALCL among patients with breast implants, and the National Breast Implant Registry collects baseline data for breast implant procedures and follow-up data on reoperations. In 2015, the Tufts report on a large-scale systematic literature review was published. This systematic literature review found insufficient evidence of an association between breast implants and lymphoma, brain cancer, cervical cancer, rare connective tissue diseases, and rare neurological events. Based on this publication, the FDA concluded that using case control studies for the 5 endpoints would not provide additional value, and the case control studies were terminated. The FDA has different post-market surveillance tools to continue monitoring for these rare endpoints, including medical device reporting, analysis of incoming signals, and collaborations with stakeholders in the US and internationally. Since the 2011 panel, the FDA has maintained public web pages updated throughout the years, including data on the post-approval studies and a breast implant informational web page. Finally, recently, compliance actions were issued on the new enrollment smaller cohort studies for Mentor memory shape device due to low enrollment and for Sientra due to low follow-up rates. This concludes my presentation. Now you are going to hear from each manufacturer. They will present more detailed information on the progress of their post-approval studies, and you will have the opportunity for clarifying questions after the break. Later in the day, there are going to be presentations that will include data from post-approval studies. Also in the afternoon, you will hear more information on the two registries that I mentioned in my presentation.
Good morning, members of the panel, FDA, and the breast implant community. I'm Dr. Stephanie Manson-Brown, a plastic surgeon and the Vice President of Clinical Development for Device at Allergan. At Allergan, we are committed to the health of patients, understanding science, and providing transparent communication to surgeons and patients. We welcome the opportunity to discuss the important topics that we are going to discuss over the next 2 days. I will start by giving you a brief background on breast implants. I will then talk to post-marketing monitoring, BIA-ALCL, and breast implant illness. Breast implants are incredibly important for the millions of women who choose to have them implanted worldwide. Allergan breast implants are supported by significant clinical evidence, including more than 500,000 patient years from clinical studies and a large body of published literature. Surgeons have 2 implant surface options to meet the individual patient needs. Smooth implants are round only. They compose around 90% of the breast implants used in the US today. Textured implants are both anatomical and round and are used in about 10% of surgeries in the US. Outside the US, these rates are reversed. The key benefits of breast implants include psychosocial improvements such as quality of life and sexual well-being. They provide restoration of physical form for congenital abnormalities, as well as for patients who suffer from loss of volume due to aging or pregnancy. They also provide an important option as part of breast cancer care, such as post-mastectomy. As with all medical devices, patients and surgeons must give careful consideration to the risks as well as the benefits of breast implants, regardless of implant surface. Textured implants, including BIA-ALCL, provide other benefits. These include anatomical shape, improved tissue adherence, which is important for tissue stabilization, implant stabilization, and there may also be a reduced capsular contracture rate. However, cases of BIA-ALCL have been reported in patients with an implant history that includes textured implants. What is important is that the prognosis is excellent, especially when identified early and treated appropriately. While each patient and surgical situation is unique, the literature supports textured implant use for aesthetic preference, primary cancer reconstruction, compromised soft tissue, congenital abnormalities, and patients who've had previous capsular contracture. Once again, however, a thorough discussion of the benefits and risks associated with implants is critical. I will now discuss our post-market monitoring programs. Following the 2011 advisory panel, FDA worked with industry to provide comprehensive post-market monitoring of adverse events. This program can be considered in 3 parts: post-market surveillance, the National Breast Implant Registry, and a large post-approval study. Additional post-approval commitments include completion of continued access studies through 5 years, group studies of patients, of patient labeling, and ongoing analysis of all returned devices. Post-market surveillance includes medical assessment of adverse event reporting and evaluation of safety trends. The National Breast Implant Registry collects baseline data from all newly implanted patients and those requiring reoperation. It improves time to identification of events and evaluates signals across multiple registries. Allergan currently has one ongoing post-approval study with 3 arms. The BIFS arm, which collects data for round implants, the 410 arm that collects data for anatomical implants, and the NBIR arm that collects data on reoperations similar to that of the National Breast Implant Registry. Here we see the status of the 3 arms of the long-term post-approval study. There are more than 53,000 patients enrolled in the 3 arms. The BIFS arm is fully enrolled with 2,000 patients. The 410 arm is partially enrolled with 421 patients. Patients who are enrolled in BIFS and the 410s arm complete questionnaires annually and return to their surgeons for scheduled office visits at 1, 4, and 10 years post-implantation to collect information on rare disease, neurological and rheumatologic signs and symptoms, as well as device-specific endpoints. Compliance with the questionnaires overall is high, in a range of around 70 to 80%, showing engagement in the study arms. We are working to improve office follow-up visits for patients by increasing contact through email, phone, text message, and mail. We're also taking measures to increase investigator engagement. Our post-market monitoring program provides important information to evaluate the benefit-risk profile of our implants. I will now talk about BIA-ALCL. Patients with BIA-ALCL can have an excellent prognosis when identified early and treated appropriately. BIA-ALCL is an uncommon, slow-growing T-cell lymphoma that typically presents with fluid around the implant, but in some of these cases it can extend beyond the capsule. The median time to onset is approximately 8 years, although the range is broad. Although the etiology is not fully understood, literature reports that higher implant surface area may increase the risk of BIA-ALCL. The leading hypothesis centers around biofilm, and there are 3 likely factors that contribute to this, including procedure, product, and patient. During a procedure, bacteria can be introduced in the surgical environment. The higher surface area of a textured implant may increase the risk of bacteria accumulation. This bacterial contamination and biofilm may result in long-term inflammation. And finally, a patient's genetic predisposition may add to the inflammatory response, resulting in transformation to BIA-ALCL. Here we see the incidence of BIA-ALCL reported in textured implants from the literature. As you can see, BIA-ALCL, while uncommon, is variable across countries. Additionally, we see a wider range of incidences reported in Australia, which may speak to a clustering of cases, potential genetic or surgical technique components. Allergan's post-market surveillance data shows a worldwide BIA-ALCL incident rate of 1 in 32,000 when BIA-cell textured implants were in place at the time of diagnosis. When we look at the US, we can see an incidence rate of 1 in 16,000. Data from our 410 continued access studies, which included only BIA-cell implants, shows an incidence rate of 1 in 3,000. These rates for BIA-cell are higher than reported across manufacturers and may represent the effects of procedure, patient genetic predisposition, and/or environmental factors. Evidence suggests that BIA-ALCL mitigation can be effective. To mitigate the introduction of bacteria in the surgical environment and subsequent biofilm formation on high surface area implants, an enhanced 14-point aseptic protocol has been proposed. Of the 14 points, enhancements include changing gloves between implant sites, soaking the implant in antiseptic solution, and the use of minimal touch technique. When these and other steps were taken, researchers reported 0 cases of BIA-ALCL in 42,000 BIA-cell implants with a mean follow-up of 11.7 years. These data underscore the value of continued communication on the importance of aseptic technique. In addition to mitigation strategies, evidence suggests that BIA-ALCL treatments are effective. When patients notice swelling or less commonly pain, it is important that they seek medical support early because early identification and appropriate treatment are critical for best outcomes. For the large majority of patients, implant removal with surgical capsulectomy alone is completely effective. In addition, a novel targeted treatment in advanced disease is effective with complete remission being demonstrated with brentuximab. We at Allergan remain committed to improved awareness through educational activities for surgeons and primary care providers, working with international medical societies to increase awareness with patients and physicians, global scientific roundtables, online seminars, consensus statements and journal supplements, and making patient materials available, including a website and brochures. Secondly, Allergan realizes insurance coverage can be an issue, and we are committed to the ongoing use of internal resources to assist surgeons in obtaining coverage for patients in these circumstances. Excuse me. And finally, we provide financial assistance to patients for seroma evaluation and for any treatment associated with BIA-ALCL. Furthermore, Allergan remains committed to improved awareness through research. We absolutely want to understand the cause of disease so we can help patients. We are doing this through both independent and internal research. With independent research, we are supporting work on immunology, looking into the cause of BIA-ALCL and genetic associations. Internally, we're working on infection control through the efficacy of aseptic solutions and exploring the impact of textured surface area on bacterial colonization and developing lower surface area textured implants. Our last topic is breast implant illness. As noted by Drs. Gottlieb and Schurm from FDA, there are patients who are concerned that the symptoms they are suffering from are related to their breast implants. There are over 80 signs and symptoms that have been reported under the term breast implant illness, such as cognitive issues, fatigue, and muscle pain. We empathise with these women and can only imagine how distressing this is for them. While no established case definition exists, the time to onset following implantation varies by patients. It is imperative that we seek to understand breast implant illness, despite the challenges with clinical evaluation. The key challenges are, firstly, we don't currently have an established case definition. Secondly, similar symptoms can present in patients without breast implants. And third, we lack standardized assessment tools to compare data that have been collected. However, currently we are actively monitoring our post-approval study data to look for links between implants and symptoms. We also regularly communicate with FDA regarding post-market surveillance and provide a medical assessment of every single reported event. With these next steps in mind, our recommendations are for close collaboration between patient groups, industry, regulators and experts. We want to continue work on improved symptom to disease mapping and also recommend independent epidemiological review of signs and symptoms data from large post-approval studies. So let me close by highlighting the following points. Breast implants are backed by significant long-term clinical experience and comprehensive post-market monitoring. Evidence supports that breast implants, including BIA-ALCL, textured implants, provide important benefits to women who choose to have them implanted. The incidence of BIA-ALCL is low, and when identified early and treated appropriately, prognosis is excellent. We continue to listen to patients and evaluate signs and symptoms from each patient case individually. Evidence supports that the benefits of breast implants outweigh their risks, and we are committed to working with FDA and other parties to get best outcomes for patients. Thank you for your time.
Thank you for your presentation. I'll now ask for representatives of Mentor to make their presentation.
Good morning, Mr. Chairman, members of the Advisory Committee and the FDA. My name is Raina Doria. I'm Vice President of Regulatory Affairs supporting Mentor. At Mentor, patient safety is our first priority. We want to thank you for the opportunity to present our perspective on breast implant safety and risks. I'll begin with an update on the potential risk factors associated with breast implant-associated anaplastic large cell lymphoma. I'll then present our data relative to the occurrence of systemic symptoms, followed by a commentary on the use of registries for the continued surveillance of breast implants. I'm joined today by additional experts who can help me answer questions as needed. Mentor gel and saline breast implants are supported by long-term clinical data, including 3 10-year prospective clinical trials. They're sold in more than 80 countries and have been chosen by millions of women worldwide for over 30 years. This slide captures the number of observed patient years for some of the key post-approval studies completed using our gel-filled breast implants. It also reflects our 2 prospective post-approval studies that are currently being conducted to address some of the unanswered questions related to breast implant safety. Last week, Mentor received a warning letter for the combined cohort study, specifically related to the enrollment in the memory shape group. The memory shape implants are available with a texture surface only. Over the last several years, the use of textured devices in the U.S. has decreased substantially. As a result, Mentor has been challenged in enrolling this study group, despite taking steps to increase enrollment. We look forward to working with the FDA to address these concerns. So let's begin with BIA-ALCL. While highly curable if detected early, BIA-ALCL is a serious condition. It is generally accepted that women with breast implants are at an increased risk of developing this lymphoma. What is not fully understood is why. Many factors have been suggested as contributing to the development of BIA-ALCL. The true causality of this disease is likely multifactorial. Recent publications have noted differences in the number and type of bacteria, referred to as biofilm, present in the capsules from patients diagnosed with BIA-ALCL. Others have suggested that particulate matter present in the breast capsule may be a contributing factor. In fact, our own research has shown that implants from different manufacturers have varying amounts of free or loosely attached silicone particles on their surfaces. More recent studies have suggested genetic predisposition, and some have pointed to surface texture as an important influencing factor, which I will discuss next. Implant surface texture varies greatly across manufacturers. Looking at the scanning electron micrograph images of implant surfaces for various manufacturers, we see the surfaces are quite unique. Mentor imprinted shell surface shown on top has small peaks and valleys, while others have a lattice-like pattern and still others show holes or crevices. These patterns create differences in surface area. Studies have suggested that the greater the surface area, the more bacteria may adhere to the implant surface. A greater amount of bacterial biofilm is thought to contribute to a higher level of chronic inflammation, which may lead to the development of BIA-ALCL. This is reinforced by published data which show that textured implants made by different manufacturers have different BIA-ALCL occurrence rates. This graph shows that the cumulative proportion of patients with BIA-ALCL over time with Mentor texture implants remains low compared to other textured implants with a greater surface area. While not a randomized controlled study, this observational study analyzed all reported cases of BIA-ALCL in Australia and New Zealand between 2008 and 2018 and took into account the surface texture as well as texture sales data dating back to 1999 obtained directly from the leading breast implant manufacturers, including Mentor. These 2 pieces of information allowed for the risk of BIA-ALCL to be estimated per specific implant and surface type. For Mentor imprinted texture implants, the risk of BIA-ALCL was rare, 1 case in 86,029 implants. This incidence rate was 16 to 25-fold lower than that observed with other textured implants. Other published BIA-ALCL studies conducted in several different countries reinforce these results. The number of BIA-ALCL cases reported in patients with Mentor implants is low in comparison with the total number of cases identified. For years, Mentor has maintained either higher or roughly equal breast implant worldwide market share with the next leading manufacturer. Therefore, the low number of BIA-ALCL cases cannot be accounted for by differences in sales volume. While Mentor textured implants have a low rate of BIA-ALCL, it remains a significant concern for us. However, textured implants offer important benefits for patients and do still have a place in the array of patient choices. These benefits include reduced risk of reoperation due to capsular contracture in subglandular augmentation patients and asymmetry in reconstruction patients as compared to smooth. In addition, textured implants offer the benefit of less movement and rotation within the capsule. Finally, shaped implants are an important option for physicians and patients, and they're only available with a textured surface. We would also like to take this opportunity to comment on some recently introduced breast implant classification systems that were designed to characterize surface properties. It's our position that implant-specific long-term clinical data are the best reflection of an implant's performance, since benchtop classification methods are not harmonized and, more importantly, are not clinically validated. Now I will shift topics to systemic symptoms. Some women with breast implants have reported a range of systemic symptoms. These may present differently in different patients. And while the causes of these types of symptoms can be difficult to determine in any person, we consider patient safety and reported symptoms very seriously, and we understand the need to monitor them continuously through both internal and external sources, including our own clinical study data and safety surveillance activities. We would like to share a few findings now, and additional data has been provided in the briefing packet. We've analyzed data from our memory gel and memory shape core studies to look at various systemic symptoms. Presented here are the percentages of new reports over time of fatigue, insomnia, and joint pain after implantation of a memory gel implant on the top row or a memory shape implant on the bottom row. The line graphs show no consistent increase in reports of newly developed fatigue, insomnia, or joint pain with longer exposure to the implant. However, Mentor is committed to continuing to examine the possible connection between systemic symptoms and breast implants through grants and registry support, our own internal extensive ongoing post-market surveillance, and of course, post-approval studies. This brings us to our next topic, the use of breast implant registries for continued surveillance of breast implant safety. Today, you will hear about the National Breast Implant Registry and the Profile Registry. Mentor believes that these registries can be used to address some of the open questions related to breast implant safety. The NBIR will allow surgeons and manufacturers to track and trend their data using its analytics capabilities. The Profile Registry is already filling in the gaps on BIA-ALCL cases in terms of the number of cases and critical details so that potential risk factors can be identified. Here are some of our specific recommendations to improve the NBIR's collection of clinically meaningful data. We're suggesting that a random sampling of women participate in a sub-study that allows for the collection of additional risk factors at the time of entry into the NBIR and ongoing thereafter. Examples of additional risk factors to be monitored include family medical history and complete breast implant history. Genetic marker testing may also be conducted, as recent studies have shown that some patients may be genetically predisposed to the development of BIA-ALCL or systemic symptoms. Finally, capsular tissue may be analyzed for biofilm at the time of explantation. Equally important is the collection of outcome data, such as the occurrence and the severity of immunological, rheumatological, and neurological symptoms. We would recommend that monitoring does not stop at implant removal, but that valuable information can be collected by the continued collection of data post-explantation. A patient's quality of life should also be assessed using a validated tool such as the BreastQ. In summary, Mentor fully supports the NBIR and considers this registry, along with the Profile Registry, as our best means for collecting long-term clinical data that will inform us about the safety of breast implants. As patient safety is our first priority, We support open and transparent dialogue so that women have all of the information needed to make informed choices about their breast surgery. To close, we would like to emphasize that we see this effort as a shared responsibility. We look forward to the discussion today and partnering with surgeons, patients, and the FDA to identify additional ways that we can educate patients, their caregivers, and their physicians about the benefits and risks associated with breast implants. Thank you very much.
Thank you for your comments. We'll now hear from representatives of Sientra.
Good morning. Sientra is pleased to present today to the General and Plastic Surgery Devices panel of the Medical Devices Advisory Committee. My name is Joanne Kuhn, and I'm the Vice President of Regulatory Affairs and Quality Assurance at Sientra. I am joined by my colleague, Rosalind Diancelli, Vice President of Clinical and Medical Affairs, and Dr. Jennifer Harrington, Sientra's Medical Director. Patient safety is our highest priority, and although not required by FDA as a condition of PMA approval, we believe that providing our products to only board-certified plastic surgeons results in the best patient outcomes. We are the only company who supplies our implants solely to board-certified plastic surgeons. Our core clinical study is the largest pivotal breast implant study in the U.S., and our 10-year data from this completed long-term study demonstrates that our Sientra Opus implants remain safe and effective for use in breast augmentation and reconstruction. Based on our commitment to collect long-term, real-world data to advance the science of plastic surgery and optimize patient outcomes, we will continue to support the research and educational opportunities through our partnerships and collaborations with board-certified plastic surgeons, medical societies, and other medical and scientific experts. And based on our confidence in our long-term implant performance and commitment to patients and surgeons, Sientra offers the Platinum 20 program, a 20-year implant warranty, the longest duration of coverage and most complete warranty in the industry. As further commitment to patients and the advancement of education and awareness, Sientra developed the Full Circle platform, a first-of-its-kind charitable program that supports breast cancer nonprofits committed to making a meaningful difference in patients' lives. In supporting these philanthropies, Sientra donates a portion of revenue from every Opus breast tissue expander sold to the Full Circle Fund. Turning to our portfolio of products, each Sientra Opus breast implant is composed of a silicone elastomer shell filled with our high-strength cohesive 5th-generation gel. Sientra Opus implants are available in a range of shapes, profiles, and sizes, as well as in smooth and textured shell surfaces. Sientra's unique textured shell surface is created by our proprietary heat volatilization process. The next section outlines Sientra's post-approval studies. Per our PMA approval order, we have 6 conditions of approval. These conditions include conducting long-term clinical studies, conducting a focus group study concerning our patient labeling, and participating in the development and implementation of the National Breast Implant Registry. As you can see from the slide, we have successfully completed 3 of the 6 commitments, and 2 are ongoing. We completed our 10-year PAC study, which is the continuation of our pivotal core study, our 5-year post-approval continued access study, and focus group study that informed our patient labeling. One post-approval study was rescinded by FDA because it would not provide any additional value, given that the Tufts University systematic review showed a lack of evidence associating silicone gel-filled breast implants with several rare events. Our 10-year U.S. PASS study is currently ongoing, having just completed 3 years of follow-up. This one post-approval study is the subject of the recent warning letter FDA issued to us last week related to our follow-up compliance. Even with Sientra's concerted and continued efforts, including patient and site compensation, a combination of repeated contact methods and study site assistance, our follow-up compliance is lower than expected. There are industry-wide challenges regarding achieving sufficient patient follow-up in clinical studies. In Sientra's efforts to contact patients for follow-up, participants' reasons for not complying with study commitments include the challenges of everyday life, such as childcare and work responsibilities. Furthermore, the study population is generally healthy, Most are not having any problems with their breast implants and therefore do not feel the need to return for study follow-up visits. We're currently examining alternate and innovative ways to address this challenge. We are committed to meeting patient retention requirements and will work with the agency to immediately address this important issue. Going forward, additional strategies include increased site and participant support, including increased financial incentives and frequency of contacts, as well as expanded frequency of online and social media searches to locate participants. Sientra will work with study sites to evaluate innovative and more effective strategies to address these challenges. Registries can lead to better utilization of resources, and data collection across a significant population of women receiving breast implants may address challenges experienced with traditional post-approval studies. Since its inception, Sientra has been an active participant in the development and implementation of the National Breast Implant Registry, which you will hear more about later today. We remain dedicated to the registry as a member of the steering committee and by providing funding along with other contributors to support the registry charter. A unique aspect of the National Breast Implant Registry is its intent to serve the dual purpose of also facilitating FDA's mandatory breast implant device tracking requirement. This reduces the burden of multiple data collection efforts for surgeons and their staff, and therefore functions as an incentive to the plastic surgery community to contribute their patient data to the registry. Moving on to the long-term data we've already collected in our 10-year PAC study. Sientra's completed PAC study is the largest pivotal study conducted in the U.S., including nearly 1,800 patients and over 3,500 devices. Devices implanted included an almost even split of surface device characteristics. Our 10-year PAC study data for the primary augmentation cohort included over 1,100 patients. Regarding key complications, capsular contracture was reported at approximately 13%, rupture at 8.5% in the almost 400-patient MRI cohort, and reoperation at 24%. For the revision augmentation cohort, rates of these same key local complications were similar to the primary augmentation cohort. Of note is that the most common reason for reoperation was breast implant style or size change. In the primary reconstruction cohort, capsular contracture hovered around 16%. Rupture was reported at 16.5% and reoperation at a rate of about 48%. No ruptures occurred in the revision reconstruction cohort, and capsular contracture and reoperation are similar to the primary reconstruction cohort. In the PAC study, over 40 individual connective tissue disease-related signs and symptoms were collected and analyzed using 13 multi-symptom categories, including the categories of joint, fatigue, and fibromyalgia. For the pooled augmentation and revision augmentation cohorts, compared to before having implants, there were no significant increases in any of the 13 CTD categories. However, there were significant decreases found for 3 of the categories: neurological, endocrine, exocrine, and vascular. No significant increases or decreases were found across any of the 13 CTD categories in the reconstruction and revision reconstruction cohorts. Sientra's 5-year PACA study arm was completed in 2013 and included augmentation and revision augmentation cohorts. The PACA study included over 2,500 patients and over 5,000 implants. Similar to the PAC study, there was a fairly even percentage of smooth and textured devices included in the study. The augmentation cohort included over 2,000 patients and revealed relatively low rates of capsular contracture, rupture, and reoperation through 5 years. No ruptures occurred in the PACUS revision augmentation cohort of almost 500 patients. Capsular contracture occurred at around 13%, and reoperation hovered around 31%. Thank you for your attention. I'll now turn the presentation over to my colleague, Rosalind D'Ancelli, to discuss our new enrollment post-approval study and the topic of BIA-ALCL.
Thank you, Joanne. Good morning. We commenced our post-approval study upon FDA PMA approval. Are you? I don't think my slides are up.
Wait for slides.
Okay. The 10-year U.S. post-approval clinical study was designed to study the real-world, long-term clinical performance of Sientra's implants under general conditions of use. Over 5,000 implant participants were enrolled and 300 plastic surgery controls at 138 United States clinical study sites. The study is currently in its 4th year of follow-up, and as discussed, continued and concerted efforts have been employed to increase that follow-up. Looking at the key complications thus far, for primary augmentation, there's a 1.6 capsular contracture rate, 3.9% rupture rate, which includes unconfirmed and confirmed ruptures, and a 6% reoperation rate. Within the revision augmentation cohort, there is a 4.1% capsular contracture rate, no ruptures, and 11.8% reop rate. For both reconstruction cohorts, capsular contracture and reop rates are similar, and there were no ruptures in either of the cohorts. On the topic of BII, we have studied the signs and symptoms by collecting over 30 individual symptoms, such as fatigue, joint pain, from participants, both implanted patients and control participants, at 2 years. These symptoms were analyzed in 2 categories: rheumatologic and neurologic. The incidence rates importantly found that there was no statistically significant difference between the control and the implant group. Another very important topic of this panel is breast implant-associated ALCL. Sientra takes BIA-ALCL very seriously and continues to support all of the medical research, education, awareness, and initiatives to better understand this condition. This important topic will be discussed in more detail later today by both Karen Nass from FDA and Dr. Mark Clemens from MD Anderson. In regards to Sientra's reported cases in patients with BIA-ALCL, we have 3 primary cases. They were diagnosed between 6 to 10 years post-operative. And we have 2 non-primary cases. These patients both have a similar history. Both were revision reconstruction patients with previous implants from another manufacturer for 9 and 13 years. Both patients were explanted due to seroma and then re-implanted with Sientra devices with subsequent seromas approximately 1 year after placement. For our 5 patients that have been diagnosed, the implants and capsules were removed and there was no further treatment. These patients all remain disease-free, most importantly. ALCL rates vary among implants, geographics, and many other factors, as you have heard and you will hear further. Recently, FDA reported a risk rate range of 1 in 3,000 to 1 in 30,000. A recent peer-reviewed publication from Calabrese et al. Reports a Sientra rate of 1 in 200,000. Our professional outreach is one step we take to support BIA-ALCL research and education. The joint statement you see here is one example of creating awareness and information to plastic surgeons on the known risks, symptoms, diagnosis, and treatment for BIA-ALCL. In addition, we sponsored 2 recent education publication supplements on ALCL and are a contributor and member of the BIA-ALCL Fund that provides financial assistance to under and uninsured women who are diagnosed and need surgical treatment. In addition to these joint efforts, we drive numerous education materials. Our product labeling provides information related to BIA-ALCL, as well as all other surgical outcomes, considerations, benefits, and risks. Sientra's Surgical Best Practices 14-point plan is authored by expert BIA-ALCL researchers, and this resource educates surgeons on best surgical practices to reduce bacteria-related implant complications. All of these efforts and communications were driven by Sientra in order to support research and increase awareness to plastic surgeons and their patients. Patient safety and product quality is Sientra's highest priority, and that is why we only provide our implants to board-certified and board-eligible plastic surgeons the most highly trained to perform these procedures. We will continue to be guided by the science behind our products. The final results of our 10-year core study demonstrate that Sientra's implants continue to be safe and effective, and importantly, the majority of patients report high satisfaction with their breast implants and their decision to undergo breast implantation through 10 years of surgery post-op. Sientra appreciates the value that breast implant registries contribute to this growing body of knowledge. To that end, we will continue to actively support the NBIR and collaborate with experts, societies, and FDA to increase education and research. Sientra recognizes that this research is important for women and that the decision to undergo breast implant surgery is a very personal choice. Sientra is committed to safety and wants women to feel confident that they are making an informed decision based on all of the benefits and risks of Sientra's extensively researched FDA-approved breast implants. Thank you.
Thank you for your comments. We'll now hear from representatives of the Ideal Company.
And to advance it is backwards. Good morning, everyone. Long morning so far. My name is Robert Hamus. I'm a board-certified plastic surgeon, and I've been in private practice in Dallas for 37 years. Listening to my patients over the years, I realized that there was a need for a new type of breast implant, something really quite different than had been on the market. I was listening to women talk about why there wasn't something that combined the best of both. And I thought that maybe there would be a way to develop a solution to some of the problems with the existing saline and silicone gel implants, and that would require a whole new technology. So I think we do need a new technology implant, and that's what I set about developing shortly after the gel moratorium in '92. The silicone gel implant is really old technology. It has a nice natural look and feel, and the cross-link silicone gel supports the shell, so it supports tissue in situations like reconstruction. But our society wants more natural things these days. Organics is the word. And the gel in the implant concerns some women. Rupture replacement with a silicone gel implant typically involves a capsulectomy, a little more complex procedure, and taking out a ruptured gel implant is a mess. I think I speak for every plastic surgeon. It's certainly not something you look forward to because of the nature of the gel and how it sticks to the tissues. Ruptures are silent, and we've talked about needing detection with an MRI scan. And this is the 10-year rupture data from the clinical trials for primary augmentation. And I think it's important to note that women are bothered by the idea of a ruptured implant. It doesn't matter to them whether it's intracapsular or extracapsular. Ruptured is ruptured, and they just don't want a ruptured implant in their body. But what happens after 10 years? We see 10-year data thrown around a lot, but this is just an example. If you can follow these lines and look up in the future, the rates are really quite high. So how have women viewed their implant choices? The saline implant, the water balloon, certainly has the safety of saline and no need for MRI scans, but there's compromises. It has an unnatural feel and there's no support inside the implant, so it collapses when upright. The silicone gel implant, of course, has the benefits that we talked about, natural looks and feel, but the compromises are that the ruptures are silent and you need an MRI scan to diagnose rupture. So I think women clearly want a third choice. They'd like the best of both. And this is what evolved after many years of work and development, and it's a saline-filled implant. There's only saline in this, but no silicone gel at all, and the layered shells provide the structure, much like cross-linked silicone gel does. So the shells, or baffle shells, control the saline movement, and what this does is alter the fluid dynamics so that the implant has a feel very similar to natural breast tissue. We did our clinical trial and started in '09. We're at the 8-year mark now, and our data is looking very good. We're very pleased that the rupture rate, compared to gel implants usually, is low. and our capsule contracture rate is favorable as well. So performance-wise, the implant seems to be doing well from the trial. So how do women view the ideal implant? We've tried to understand quite a bit of what's important to women. One of the things they really like is the ability to look in the mirror and know their breast implant is intact. There's no risk of silent rupture, no need for MRI scans, and of course saline is natural and absorbed in the case of a rupture. We've been on the market for 3.5 years. Most of you have probably not heard about it, so I'm pleased to have the opportunity to tell you about this implant. What we have found is that women who choose ideal implant are more health conscious. They've become well informed through online research. Many have had prior implant surgery, perhaps ruptured gel implants, and want them changed. The surgeons who choose this implant and offer it to their patients tend to be very unbiased. They make a point of that, and they want to offer their patients all 3 types of implants: the saline water balloon, the silicone gel implant, and the structured ideal implant. In this short period of time, we've fortunately not seen any cases we're aware of with ALCL or even breast implant illness. Mastectomy is kind of an interesting situation for women. ASPS statistics show that only 5% of breast reconstructions are done with saline-filled implants, the water balloon, and as you can understand, there's no support and you don't have a very good feel, especially with thin tissue over it. So 95% of breast reconstructions with an implant are done with silicone gel implants, which we said earlier supports the tissue. Now, ideal implant also supports the tissue, and it also has a natural feel, but also the advantage of having only saline, which many women would like. But it's not an FDA-approved option for reconstruction because being a small company, a startup, we did not do reconstruction in our clinical trial. So women cannot be informed about this option by us, and women effectively have no choice if they're going to use an implant for reconstruction. They're pretty much forced to have silicone gel implant. Now, if there was a reconstructive indication for the ideal implant, women would have an approved alternate to silicone gel, which they may like. They might appreciate no silent ruptures, no MRIs, no capsulectomy if there's a failure, and still have a natural feel. Women could be informed then about this option. They could, on their own, compare the benefits and compromises of all 3 implant types, and they could make an informed choice. Women could choose the option that they think best fits their own personal needs. So in the practice of medicine, we have found that over the last 3.5 years, about 100 surgeons have used the ideal implant for breast reconstruction. Many have repeatedly used it, so that means they're happy with the results and doing more. What the surgeons tell us is they feel they're getting good outcomes, they have happy patients, and this implant is effective for breast reconstruction. Women say it fills an unmet need for an alternative to silicone gel, and who knows, it may become the preferred option for mastectomy reconstruction in the future. How do we get to a reconstructive indication? Well, fortunately, there's a real-world experience pathway available where we can collect safety and efficacy data from the cases that are already done from the medical records. These are verifiable source documents that are subject to monitoring, which would provide accurate and reliable real-world data and real-world experience with the ideal implant. This data should be of sufficient quality to support FDA's regulatory decision. And after all, we're simply looking to add a reconstructive indication for an already approved implant with over 8 years of clinical trial. And we're planning to start just such a study very soon. So this implant was developed to be a solution to some of the problems with the existing implants. Thank you for your time.
Thank you for your comments. We'll now take a 10-minute break and return at 10:25. At that time, we will have a 15-minute period for members of the panel to ask clarifying questions of the 4 representatives of the companies which make implants. So consider your questions during the recess, and we'll start that immediately on return. Thank you.
Lower it a little bit. Lower the whole thing just a little bit.
Okay, so. especially the red dots, you can see easily. You can see this part.
They can't.
No, we don't have that, huh? I can't see now half the thing needs. That's the problem, man. Yeah, I know. Understand. Who's the most? It's
Yeah,
Jason.
Could we please reconvene? Members of the panel take their seats. Could we have representatives of the 4 companies please take their place in front of the podium so that we can ask questions? Could all of the representatives please take their position over here in front of the podium so that we can speak up to the microphone directly? And panel members, please raise your hand if you have a question. Yes. Dr. Kowalski. Dr. Portis.
Yes. Well, I guess at first I have a comment and then I have some questions. I just want to say that the repeated assurances that ALCL is highly treatable is small comfort to women who are undergoing the physical, emotional, and financial realities of having this disease. So as a patient myself and as the patient representative, I really urge you to consider that in the presentation, because being told it's not a problem, we can treat it, when for many of these women, they already have had a primary cancer diagnosis. So just something that I want to mention. But I do have some questions. So when you're talking about doing further research, I wonder what underlying risk factors and genetic predispositions you're planning to look at. Also, any intention to look at diverse populations. And my third question is, have you considered giving a complete ingredient list so patients would have that information?
Who would like to address that?
Reina Doria, mentor. So your first question, if you could repeat your first question.
What underlying risk factors and genetic predispositions do you think it would be useful to look at?
Certainly. So underlying risk factors that we would recommend include family history of potential diseases or rheumatological or neurological disease states, and also a history of cancer or anything else like that. And then you asked about diversity, and we do include diverse populations in our clinical trials. So we absolutely do that, and we think it is important to include a diverse patient population.
So do you think that you're already seeing some predisposing factors? I know there was some mention in some of the materials that some of the companies said about things like vitamin D3 deficiencies and other things like that.
We have seen in published literature that there is a potential predisposition. I don't know if there's enough data to support that yet, so we do recommend collecting all of that. I would welcome Dr. John Kennedy, who's from our medical affairs group, to comment more from a clinical perspective.
John Kennedy, Medical Director for Mentor. I'm also a plastic surgeon. Your question was around vitamin D3 deficiencies and other pre-existing types of things. For a lot of diseases, there's continually evolving insight into pre-existing types of issues. And as Reina said, I think a lot of those are first discovered in studies that are published in the literature. And then it becomes a matter of trying to sort out which of those are likely to have the biggest impact or be most frequent to be included in the clinical study. So yes, certainly we would look at those going forward. Anybody else want to?
Let's move ahead to the next question if we can. We've got a lot to cover.
Okay. Dr. Jason Hammer, Allergan Global Medical Affairs.
At Allergan, we're conducting basically 3 categories of research currently. We're conducting our internal research, we're supporting external research, and we're involved in new product development. For internal research, we're evaluating the impact of the texture surface areas. We're looking at antiseptic solutions. External research is focused mostly on epidemiology, immunology, basic science, and genetics, some of the contributors that have been postulated in the literature and evolve towards that leading of biofilm and how it interacts with the implant surface. And finally, we are actively exploring new implant technologies.
Thank you. I have a question for the manufacturers who make both silicone and saline implants. If it's not beyond your proprietary information, is there any difference in the capsule of saline versus silicone implants?
Kelly Carty, Director of Regulatory
Speak up a
Affairs
little
for
bit.
Allergan. I'd like to ask Dr. Mark Jewell to speak about that.
The ones that enclose the shell of the implant itself.
Mark Jewell. I'm a practicing plastic surgeon from Eugene, Oregon, associate clinical professor at Oregon Health Science University, and a consultant for Allergan. You've asked the question, is there a difference between saline and silicone filled implant shell capsules? And the answer is they're very similar. A smooth capsule with a saline device, a smooth capsule with a silicone device that is intact basically is the same. Textured response with a BIA-ALCL shows tissue integration with an ordered array of collagen on both implants.
Thank you. Yes, Dr. Rogers.
I was wondering if any investigations have been done regarding the impact on breast milk and chemicals or whatever is released into breast milk, as well as the impact of implants on ability to breastfeed.
Thank you, Reina Doria, Mentor. Mentor did include in our large core study as well as our past study the potential effects of breast implants on breast milk, and including offspring of patients, and we did not see any evidence of any transference of materials into breast milk.
Rosalind and Sally from Sientra. We do collect reproductive and lactation outcomes in our core pivotal trial as well as our post-approval study. And thus far in the analysis, there's been no increase or association or risks identified in those cohorts. So we're continuing to follow that, but there's been no increased concern in that area.
Thank you. Dr. McGrath.
One thing that I think will help us to understand things today is to have a better sense of how many of the implants that are currently being sold in the United States are textured versus smooth surface. I had always thought we had about a 12% use of textured implant and 88% smooth surface, but I understand from some figures now that it's probably more like 90-10 with only 10% textured, but that plastic surgeons are moving away from using the textured surface. I'd like to get a sense of what you're seeing right now with your sales figures on that roughly, proportionally. I think that would give us some help. It's entirely different from the rest of the world where you can flip those statistics almost completely.
Kelly Carty, Allergan. As you saw in our presentation, we see 90% smooth and 10% textured.
Reina Doria, Mentor. We also see 90% and 10%. We do know that only less than 5% of our sales are with the memory-shaped textured implant.
Joanne Kuhn, Sientra. I can't speak to the sales numbers, but what I can tell you is from our device tracking numbers, where we used to see about a 50% split, it's gradually moving closer to the 80% on the smooth and 20% on textured.
Okay, yes. Dr. Baldwin.
So in the long-term post-approval studies that are ongoing, what are the differences between what's captured in the questionnaire and what's captured in the office visit?
So for Sientra's study, there is a questionnaire annually, so every year questions are collected. The patients will complete symptoms, quality of life questions, measures, diagnosis, basically a full medical history, what medications they're taking. Those are collected annually from patients in questionnaires. When they are in for an office visit, there's additional collection of those endpoints as well as measures of local breast complications, so they're assessed for capsular contracture. However, even when the patients do answer their questionnaires remote online, those questions are asked as well, so the local breast complications, capsular contracture, et cetera, are collected.
Kelly Carty, Allergan, we have a very similar design. When patients, the one thing I would add to that is when patients come into the office, the surgeons confirm connective tissue diagnoses.
Same for Mentor.
I have two questions, one for Mentor and one for Sientra. In the Mentor presentation, you showed us those pictures of the different types of texturing methodology that was used and how different they looked. And that was very striking. I'm curious, texturing is also used in other types of implants, like orthopedic implants. We have smooth, I think it's all smooth in with pacemakers. Is there any comparison with any other implant in the body that might give some insights into this?
Kennedy.
John Kennedy, Medical Affairs for Mentor. Just from a manufacturing standpoint, I'll speak to ours. It's an imprinted process that goes before the silicone is cured. So for other metals, other materials like metals or other types of things, it's not a similar process.
So there is no analogy to to the disorder that seems to be linked to the texturing outside of breast implants. Is that our understanding?
Not that we can speak to from our own studies.
From the literature, there are several reports of ALCL cases in other devices, if that's what you're asking.
Yes.
Yeah, in many. There's ocular, lap band, catheter pacemakers, knee, I believe, hip. So there are case reports in quite a variety of literature of this occurrence in other medical devices.
Other devices, texturing wasn't necessarily part of that.
Not necessarily.
Okay. I also have a question about in the Sientra presentation. You had one slide where you said breast implant illness. You showed us in text that you provided some comparison between the implant and control group. And you said there were no statistically significant differences. You showed us no data. So we couldn't tell if it was powered adequately to make some type of comparison like this. Is this going to go into the peer-reviewed literature so it can be examined?
Absolutely. We have our full data set, and we've shared it with FDA, and we will share this in the interest of brevity. We couldn't include everything we wanted to. I can ask Maggie Beckstrand to come and speak up. She's our biostatistician.
No, I think we need to move on.
We're good? Okay. Okay, so there, we do have it.
All right, we need to move ahead to the next phase. So thank you all for participating, and thank you for your presentations. We'll next move to a detailed presentation from the FDA from Karen Nast and Dr. Michael DeLong.
I'm Karen Nast, a nurse consultant in the Division of Post-Market Surveillance and CDRH. I'm going to provide an overview of the MDR data for BIA-ALCL and breast implant illness symptoms. Since September 30th, 2017, 246 new MDRs were received, resulting in a cumulative total of 660 MDRs for BIA-ALCL. This total includes all MDRs that contain the term ALCL or variations of it in the event narrative. BIA-ALCL MDRs are counted for those reporting an ALCL diagnosis or treatment, or confirmed pathology or cytology test, or ALK or CD30 biomarkers. FDA staff further analyzed the 660 cumulative MDRs. Duplicate reports were excluded and supplemental reports were reviewed. We believe this data set more accurately reflects the number of BIA-ALCL reports. These data reflect a total of 457 distinct MDRs for BIA-ALCL. There were 12 death reports representing 9 patients. All 457 reports include the implant fill type. There are 274 reports for silicone gel-filled implants and 183 reports for saline-filled implants. This is a late disease, and on average, most patients present 8 to 10 years later. There are 310 reports for textured implants and 24 reports for smooth implants, and this is at the time of diagnosis. In almost 30% of the reports, we don't know the surface type. It wasn't reported. In most of these reports, the full patient history of prior implants, whether a textured or smooth surface, is unknown. Also unknown is the total number of textured surface breast implants implanted versus smooth surface implants to know if there is a higher rate of BIA-ALCL with one implant type versus another implant type. Due to missing or incomplete data, the distribution of patient and device characteristics in both data sets may not accurately be reflected. However, the FDA believes that the data in this table more accurately reflect the number of MDR reports of BIA-ALCL cases, 457. FDA is not aware of any MDRs reporting ALCL in devices other than breast implants. ALCL has been associated with devices other than breast implants in the literature. We are aware of less than 10 case reports in the literature. FDA conducted a query of the MDR database for all reports entered between January 1st, 2008 and October 31st, 2018, referring to a saline or silicone-filled breast implant, with search terms used to represent the various symptoms patient groups refer to as breast implant illness. Search terms were taken from the list of symptoms on the website Healing Breast Implant Illness. The search included over 80 terms, and the resulting 1,328 MDRs contained at least one term. The majority of these reports were submitted by voluntary reporters. Voluntary reporters include healthcare professionals, patients, and consumers. There were similar numbers of reports for saline and silicone gel-filled implants. There are 1,311 injuries and 8 death reports describing 4 patients. It is not clear that the deaths are related to BII. These reports are included because they contain the keywords searched. The most commonly reported symptoms included fatigue, brain fog, rash, joint pain, and memory loss. Some reports concerned health issues of children born to women with breast implants, leading to reported patient ages ranging from 9 to 76 years of age. The time to reported onset of symptoms ranged from less than 1 month to over 38 years. Out of the 1,328 reports, less than half provided an explant date, and of those, the time to explant ranged from less than 1 month to over 40 years. And 101 of those MDRs reported improvement in symptoms after explant. Incomplete information provided in MDRs regarding what patients perceived as improvement in symptoms or the time course for improvement prevented further analysis. It is not clear that current routine reporting accurately captures information on explantation due to BII. Although MDRs are a valuable source of information, this passive surveillance system has limitations, including underreporting, data quality issues like the potential submission of incomplete, inaccurate, untimely, unverified, or biased data, limitations of the MDR regulation. A lack of MDRs does not necessarily mean there are no problems. It is not possible to definitively determine a causal relationship between an event and the device based on MDR data alone. Finally, the incidence or prevalence of an event cannot be determined from this reporting system alone due to potential underreporting of events and lack of information about the total number of devices. These data do not represent a complete understanding of breast implant illness, and these reports alone do not demonstrate that breast implants are causing the symptoms of breast implant illness. The panel will be asked to discuss methods for assessing and addressing breast implant illness symptoms. The panel will also be asked to make recommendations regarding next steps for the characterization of BIA-ALCL incidence and its risk factors. Dr. DeLong will now speak about breast implant illness symptoms reported in post-approval studies.
Hello, everybody, and good morning. I'm Michael DeLong, a medical officer in the Division of Surgical Devices, and I'll be presenting the information that we have from the manufacturer post-approval studies regarding symptoms similar to the BII reports. In preparation for this meeting, we asked each manufacturer to provide information regarding symptoms of breast implant illness from their post-approval studies. This table illustrates the post-approval studies that are most relevant to BII endpoints. You will notice that there are two redesigned studies, one for Mentor and one for Allergan, that replaced the original large post-approval studies for these manufacturers. Recall that the reason that these studies were redesigned is because of low patient follow-up, which was discussed in FDA's General and Plastic Surgery Advisory Committee held in 2011. Please note that in order to obtain marketing approval, each manufacturer was asked to perform a core study, which involved follow-up for several years before device approval and continued patient follow-up after device approval so that patients were followed for a total of 10 years. Ideal only manufactures saline implants, and so the ideal post-approval requirement was just this continuation of the core study to 10 years. The red boxes on this slide indicate the studies that are currently ongoing. The other studies have either been replaced or have been completed. Each manufacturer has one ongoing study with endpoints relevant to BII. In November of 2018, the FDA requested that sponsors submit the most current systemic symptoms data from their post-approval studies. Each manufacturer submitted data from a different study. It is very important to note that each of these studies has substantially different protocols, preventing any comparisons between studies. Additionally, a basic understanding of each protocol is important to contextualize the presented data. On this slide, we have highlighted the studies that were referenced or submitted in response to FDA's request. Recall that the red boxes are around the currently ongoing studies. Allergan submitted data from their ongoing breast implant follow-up study, which is the redesigned large post-approval study. Mentor referenced data from their original large post-approval study prior to the redesign. Segurança referenced data from their completed core study final report, and Ideal submitted data from their ongoing core study continuation, which is their post-approval requirement. This table provides a brief overview of the study differences. As you can see, the protocols and patient populations are sufficiently different that no comparisons can truly be made between studies. We will start with Allergan's breast implant follow-up study. This is the redesigned version of their original large post-approval study that was replaced and redesigned after the 2011 panel meeting. The BIF study protocol was approved in August of 2015. The study protocol did not involve enrollment of new patients. It consisted of selecting 2,000 silicone and 257 saline Allergan implant patients from the original large post-approval study cohorts to continue to 10 years. Because the protocol intentionally selected patients from the original cohort who are compliant with follow-up, there is guaranteed 100% four-year follow-up in both cohorts. Additionally, the selection process does not necessarily eliminate follow-up biases. 95 different symptoms are included in the annual patient questionnaire, and we will focus on the 19 that are most consistent with the BII MDRs. The study was designed to use saline implant patients as a control group for assessing the incidence of these symptoms. However, because patients with saline implants have also reported BII-related symptoms and represent roughly half of the MDR reports, we will present the incidence rates in both cohorts separately without a comparison group. The relationship between these incidence rates and national norms is unknown. Incidence percentages are reported in the BIF study as the patients who did not have the symptom at baseline who report that symptom at any time point after study initiation. Therefore, the denominator for these percentage calculations is the original study cohort regardless of follow-up and may underestimate true incidence at later years as patients are lost to follow-up. This chart displays the symptom data from the silicone cohort, separated by indication. This information is found in the publicly available executive summary on page 21. All patients in this cohort have reached at least 7 years since implantation, and there is a 78% follow-up rate. The highlighted fields are all groups with at least 10% incidence, which are found to include several symptoms that may affect a patient's quality of life, such as arthritis and joint pain or confusion and memory loss. Again, the relationship of these incidence rates to national norms is unknown. This slide presents the data from the Allergan saline cohort, who have all reached at least 7 years since implantation with 78% follow-up rate. Again, all symptoms with greater than 10% incidence are highlighted, and again, the relationship of these incidence rates to national norms is unknown. In response to FDA's 2018 request, Mentor referenced data from their original large post-approval study, not the redesign after the 2011 panel meeting. This is because, after having inadequate follow-up in the original large post-approval study, Mentor's redesigned study was a new enrollment study. Due to ongoing enrollment, this study is still in its infancy, with most patients not even at 1-year follow-up by the time of the agency's request. Additionally, Mentor recently received a warning letter for inadequate enrollment in one of the cohorts in this new enrollment study. Therefore, Mentor chose to reference the 7-year data from their original large post-approval study. This study is similar to Allergan's study in that saline implant patients were used as the control group. So again, the cohorts will be presented separately without a comparator because patients with saline implants have also reported these symptoms in the MDRs. The symptoms collected differed from those in Allergan's study, but again, we will present the 12 symptoms that are most relevant to the MDR reports. This slide presents the data from the silicone implant cohort, available in the executive summary on page 22. Who have all reached at least 7 years since implantation with 15% follow-up rate. Again, all symptom groups with greater than 10% incidence are highlighted, including symptoms consistent with MDRs that may be concerning for patients such as arthritis and joint pain or persistent fatigue. Again, the relationship of these incidence rates to national norms is unknown. This slide presents the saline cohort, who have all reached 6 years since implantation with 12% follow-up. Again, fields with greater than 10% incidence have been highlighted, and again, the relationship of these incidence rates to national norms is unknown. In response to FDA's 2018 request, Sientra referenced data from their completed core study continuation rather than their ongoing post-approval study. Sientra's ongoing post-approval study was only at the 2-year time point and also recently received a warning letter for insufficient follow-up in this study, so they referenced the 10-year data from their completed core study continuation with 51% final compliance with the symptom questionnaire. Again, we focus on the 13 endpoints most related to the MDRs. However, it is important to note that most core studies are focused on local complications, and the reporting for systemic symptoms is not always as complete in these studies. In the Sientra study, no symptom was present with an incidence of 10% or greater. However, these data are from a core study and may be less complete. In response to FDA's 2018 request, IDEAL submitted data from their ongoing core study continuation. This was their post-approval study requirement. It is important to note that IDEAL only manufactures saline implants, and they are indicated only for augmentation and revision augmentation. Additionally, their study protocol did not collect data on patient symptoms and only required the enumeration of all patients referred to a rheumatologist who were not referred at baseline at years 1, 2, 3, 4, and 7. All patients in the IDEAL study have reached 8 years since implantation with 94% follow-up rate. The cumulative totals for new referrals to rheumatologists are 7.8% of the primary augmentation group and 9.7% of the revision augmentation group. It is unknown how these incidence rates relate to national norms for similar populations. Again, the protocol did not require collection of symptoms data, so symptom incidence is unknown. In conclusion, the data from the PAS are limited by follow-up and reporting issues. There are significant differences in study protocols that preclude any comparisons between separate studies. However, symptoms consistent with the MDR reports have been observed in these studies, although the relationship between these incidence rates and national norms is unknown. Thank you.
Do you have any further presentation? Okay. All right, we have the opportunity for clarifying questions from the panel.
Lynn Pavelski, this question's for Karen Nast. When you show the MDR numbers, do those include those submitted as individual MDRs and via summary reporting from manufacturers?
Thank you. The MDRs for ALCL are individual reports because ALCL is not allowed to be submitted through any other method. The MDR reports for BII are also from individual reports. We consider these events unusual or uncommon, and so they would be reported as individual MDRs.
So it's a complete representation of what the manufacturers submit, everything that you get?
As far as we're aware, yes.
I'd appreciate some kind of clarification as to what efforts you can go to obtain what I would consider to be some sort of control group. I mean, short of a randomized prospective trial, it seems to me there must be other kinds of devices or other kinds of things that the FDA monitors in which one could explore the incidence of these subjective complaints. I'm not talking about the lymphoma. I think it's very tricky. I'm very familiar with a large series of studies involving aromatase inhibitors, which have apparently major subjective complaints associated with them. And I'm trying to understand, can you get other information from studies that you deem reliable for other kinds of comparative groups of women to get some notion as to what we're really talking about here?
So a couple different approaches have been attempted. This is one question I think that we would also ask the panel is what is an appropriate control group, because the identification can be difficult. Initial studies use saline implant patients as the control group, as we discussed, but if patients with saline implants are reporting these symptoms, they may not represent an ideal control group for investigating these symptoms. Some of the redesigned post-approval studies are now using other cosmetic surgeries that do not include an implant, but it can't necessarily be assured that those patient populations are identical or similar to a breast implant patient in terms of age, demographics, and other behavioral patterns. So it is a complex issue, and it's one I think the panel could be very helpful in discussing. Thank you.
Dr. McGrath.
Just to go further with that, Dr. DeLong, in the Danish study in 2007, they had 3,000 breast implant patients and 8,000 other plastic surgery patients, all matched for age and gender. And most of those were breast reductions, liposuction, and so forth. And the differences in defined connective tissue disease was the same in both groups, and with the national population figures, the prevailing Danish registries. But the interesting thing I always thought in that study is that there was what they called non-diagnosable rheumatism complaints, and it was identical in both groups. And that's the only data that I'm aware of where we really have a feeling for a group that was matched from something that was not getting a device. And it was very telling that the numbers were quite statistically compelling.
Yes. Yes. Dr. Leitch.
For Dr. DeLong, on the Sientra data, you said that they were a continuation of the core study and the symptoms were all less than 10%. And you said that may be less than complete. What did you mean by that?
In general, the core studies are pre-market studies designed to assess the safety and effectiveness of a device before approval. And so they focus, they typically run to about a 3-year time point before the device is considered for approval. And so they tend to focus on local complications and several risks, and they may not be powered or designed necessarily to study specifically rare adverse events such as the neurologic or connective tissue disorders. So the post-market studies were often, like the large post-approval study, more focused on those endpoints. And so because it was a core study that was referenced, we don't know that it wasn't necessary. The rare endpoints were not necessarily the primary focus of that study, if that makes sense.
But if they had the questions, why wouldn't it be, and what was the duration of follow-up of that?
The duration of follow-up for their study was 10 years because it was the completion of the core study. The questionnaires just may not have had as many questions, if that makes sense.
But for an individual complaint, if it were less than 10%, the question was asked, right?
Correct. That's correct.
Dr. Lee?
Yes, I have a couple of questions for either Ms. Nash or Dr. DeLong about the MDR itself. In other device areas, we estimate the number of MDR reports versus the actual number of failed devices is very small, sometimes maybe only 1%. So do you have any feel for the MDR data for breast implants, what percentage of MDRs are reported versus, say, the number of reconstructions or the number of reoperations?
We're not able to gather incidence rates from MDR data alone due to several factors we've gone through in the presentation, including underreporting. So we're
Well, how
not
about,
able.
excuse me, I'm sorry to interrupt, but let's say there's, we saw one number this morning, there was 85,000 reoperations. So versus 85,000 reoperations in a single year, how many MDR reports would you get? If you don't know, that's okay. It's a question just to see, just to try to get some feel for the amount of reporting that actually gets done.
It's hard to say. We do get mandatory reports that meet the criteria for malfunction, serious injury, or death. We also receive voluntary reports. I don't think we can say how many reports per surgeries we get.
You know, what we could do is we can look up the number of total MDRs that we receive annually for breast implants and provide that to you at the next break. And that perhaps will help address the question so that you may be able to make the comparison to the number of reoperations that you're aware of from the literature and other
That would be
sources.
fine. I'm just trying to get a feel for, is the number as small for breast implants as it is for every other device? So,
Right. Yeah, we'll come back to you with that information.
okay, and then a quick follow-up question on that. Over the 457 cases of ALCL that you reported, over what time period were those collected?
I don't believe there was a beginning time period. Those are up to date.
But going back how far, I guess?
We received data, I think we began receiving MDR reports in the 1990s. I don't think we limited the beginning of our data.
Okay, I was just trying to get a feel for, is the number of, it seems like the number of reports is increasing with time, and I was just trying to get a feel for how many reports you're actually getting. 457 sounds like a lot, but if it's spread over 15 years, it's not so much. So I'm just trying to get a feel for the seriousness of the issue.
I think what we can do is we can give you what we've had is the increased number of cases over the past several years. We've had an increased number of cases since our 2011 report, announcing that this was a finding, and every year it's gone up annually. So perhaps that'll be informative. Now, when the first earliest case was, we would have to also go back and check in our records, but this is our full understanding of BIA-ALCL from our MDR database.
Yeah, if I may, one last quick question. We've heard that there's 457 reports of ALCL. We've heard from each manufacturer that the number of cases they know about actually are quite small, 4 or 5. So in your MDR, could you identify, actually break down whose implants were actually involved in each ALCL case? Because right now I've got 457 implants of unknown supply, and then each manufacturer is saying kind of it's not us. So I'm trying to figure out whose implants these are.
Thank you for your question. Our data oftentimes is not complete, so I don't believe we have complete data for the 457 reports. I also want to add that we do receive data that is outside of the U.S. that is reportable to us also. So we receive data for devices in the U.S. as well as outside of the U.S.
Dr. Sander.
Thank you. A couple of quick questions. One is, are there any known or validated biomarkers for BII, and has there been any attempt to identify serological measurements that could be strongly associated with the symptoms that are being reported?
As far as I know, there's no established diagnostic criteria. We do have an expert from Canada who's going to be talking about Asia syndrome, and he's done some investigating in terms of different biomarkers or laboratory tests that may be associated with that condition that may be applicable to the study of BII.
Thank you. And one other quick question. One of the things I was most struck by as I was reviewing all the literature that FDA supplied is how frequent the rupture rate is. I'm just surprised that so many times the device sort of fails fundamentally, and I don't understand that, and I was wondering if FDA, or maybe I should have asked the manufacturers, can explain what the mechanism of rupture is and why the devices aren't designed in such a way so that the risk of rupture is small.
Yeah, I agree. That would be probably the best, more appropriately directed to the manufacturers.
So FDA has no opinion on that?
We provide mechanical testing, or require that the manufacturers perform some extensive mechanical testing prior to marketing of their device. And that information is contained in the summary of safety and effectiveness that was included as an appendix in your advisory committee pack. And so that includes as detailed information as we can provide regarding the components used to create the device, as well as the bench testing performed, as well as any animal testing and all of the human clinical testing that was done pre-market.
Thank you.
Dr. DeLong, in the data from the FDA and the MDR reporting, you cited approximately a 6% incidence of ALCL with smooth implants. As far as I know, in the profile data to date, if patients who had a previous implant prior to a smooth implant are excluded, there are no incidences of ALCL with smooth implants. So while it's not a huge difference, I think it's an important difference to know if the zero number is correct or if the low incidence is correct. Can you clarify that?
We're fortunate enough to have Dr. Pusick, who heads up the profile registry, and Dr. Clemens speaking later on today, and so they may be able to tell you specifically about the information obtained from the profile registry.
Thank you. Yes.
Yeah, I have a question about the assessing the incidence of the breast implant-associated ALCL. A problem in some of the meetings that I've attended in the past is that a lot of patients with seroma have draining of the seroma fluid, and the fluid is not sent routinely to pathologists for cytologic evaluation. And I'm wondering if the FDA has played a role in trying to correct that issue, and whether there's been a change in practice in terms of assessing patients with clinical seroma.
So the FDA is hopeful that we can spread awareness of this disease process. We recently released a letter to healthcare providers. We worked very closely with the professional societies trying to make make sure, not just in plastic surgery, but any professional society that might take care of a patient who develops ALCL. And our hope is that we can increase awareness of this diagnosis so that providers are informed and patients are informed the steps that would be necessary to take to try and achieve a diagnosis or rule out the disease.
Okay. Yes, Dr. Rogers.
I have a question about BII and the wide range of ages that we've seen in some of the data, very, very young women to older women. And is there any correlation in the reporting based on age, or is it mostly linked to the length of the implant being in place?
I'm not sure that we're aware of any correlation. We can try and look into that, but I don't know that we have that kind of analysis that would link the patient age to the symptoms of BII.
This is just getting back to predisposing factors that might influence development of some of those. And it was striking to me that the indication for the implant also was correlated, seemed to be, the incidence of BII seemed to be different based on the indication for the implant. So, and there's quite an age stratification for that. So I was just curious about whether any of these reports have been looked at in terms of the demographic of who's reporting.
Right, and some of that is confounded because the revision groups are likely to be older, but they also had prior implants, and so they're likely to have been exposed to implants for longer. So those two variables are often go hand in hand.
Dr. Leitch?
One thing I would say about the question that Dr. Rogers just asked is that a lot of the reconstruction patients could be taking aromatase inhibitors, which have similar symptoms as the prominent symptoms that are listed. That could be a factor in those patients. My question was going to be related to compliance, and what are your thoughts about compliance? Is it at all related to the financial support that is given to by the companies to encourage compliance? Because it was mentioned that some of them do give incentive for compliance.
Is your question whether providing a financial incentive increases patient compliance with the questionnaire?
Right. Has that been shown?
That might be a question the manufacturers would be able to answer in terms of what financial packages they provide and what they've seen for compliance.
And I can add that, we do several things to try to think about innovative ways to promote compliance with the study so that we get meaningful data at the end of the day. I have to say that probably companies are much more compliant in getting their patients to follow up in the pre-market when a pre-market approval is being sought. And in the post-market arena, we're not as successful. What those reasons are, we're not entirely sure, but there are many strategies that FDA proposes when working with manufacturers.
Yes, Dr. White?
Yes, thank you. I just wanted to get see that I was clear in my understanding that this was to Dr. Karen Nast, commented that we're not aware of other ALCL diagnoses with other implant devices. But one of the industry representatives had mentioned some other cases of ALCL reports. Did I get that correct, that you're not aware of these cases?
That's correct. We are not aware of any cases of ALCL in devices other than breast implants being reported through our MDR system. However, we are aware of less than 10 cases.
Yes, Dr. Burke?
I just wondered if there have ever been any studies to see the components of the seroma fluid, and if there are any non-biologic, in other words, synthetic parts of the what synthetic particles or potential toxins might be in the in the Sirona fluids?
Our current recommendations regarding BIA-ALCL diagnosis focus primarily on how to diagnose the disease and sending the fluid and fibrous, the capsule for pathology evaluation. This panel, if it felt appropriate, could make recommendations about additional tests that might be done on the tissues surrounding the breast implant.
Dr. Lee?
I just had a quick question, a quick answer to Dr. White's question. I actually just ran across this weekend an odd article. In February, there was a report of a silicone gluteal implant that developed the same lymphoma. It was a single case report, but it was a silicone textured gluteal implant.
Dr. McGrath?
That was not histologically confirmed in the buttock. The patient had metastatic ALCL and had buttock implant. There's no proof that the buttock had any ALCL in it, and the buttock implant had only been there for 1 year.
I completely agree with that. I was just remarking that there was a report.
Are there further questions? Yes.
So this is Colleen Gallagher. I'm just wondering, since it seems that so much of the effort of education and everything has gone to the board-certified plastic surgeons, how many of these surgeries are done by board-certified plastic surgeons compared to those done by general surgeons or others?
I don't know that we necessarily know those numbers, at least not off the top of our head. The American Society of Plastic Surgeons provides their statistics in a survey report every year. There are also things like the American Board of Cosmetic Surgery, and I believe their members also perform these procedures, but I'm not aware of what their incidence rates are.
Dr. Portis, did you have a question?
Yeah, I wonder with the MDR, I know that there's some mandatory reporting, but do you have, I know this is a hard question to answer, but what about patients who don't know about the MDR and don't know about the information on FDA's website? It's like, how do we find those people, and what percentage do you think we are actually reaching?
I can say that we have seen a definite increase in voluntary reports in the past few years. I think some of the reasons for this are definitely the increased social media aspect. That's been increasing awareness. We definitely receive many voluntary MDRs, and we value those greatly.
Does FDA make any effort to reach more patients, to let them know of the concerns and that we want more reporting?
With respect to BIA-ALCL specifically, in the past couple of months, we recently issued a letter to healthcare providers, and this was different than the letter that we issued back in 2011. The one in 2011 just went to plastic surgeons, and on the advice of patient groups that came and talked to us, we issued a second communication. This went to all healthcare providers that we could think of that would touch a patient that potentially would have breast implants during her lifetime to promote awareness. But more definitely could always be done, and we hope that forums like this will cause individuals to go back to their communities and their societies and communicate this risk and advise people to report adverse events.
All right, we need to move ahead with the next phase of the program. I thank the FDA for their presentations. We'll move into the public hearing now. We'll proceed with the first portion of the public hearing, there being 3 more opportunities, obviously, during the 2 days. For the record, all panel members have been provided with written comments received prior to this meeting for their consideration. During the open public hearing, public attendees will be given an opportunity to address the panel to present data, information, and their own views relevant to the meeting agenda. I would also like to urge those who speak to include in their presentations whenever possible their recommendations for actions which are needed that they feel to correct the problems which they are complaining about, so that the panel has a clear idea of what they feel is needed. Commander Garcia will now read the open public hearing disclosure process statement.
Thank you, Dr. Lewis. Both the Food and Drug Administration and the public believe in a transparent process for information gathering and decision making. To ensure such transparency at the open public hearing session of the advisory committee meeting, FDA believes that it is important to understand the context of an individual's presentation. For this reason, FDA encourages you, the open public hearing speaker, at the beginning of your written or oral statement to advise the committee of any financial relationships that you may have with any company or group that may be affected by the topic of this meeting. For example, this financial information may include a company's or a group's payment of your travel, lodging, or other expenses in connection with your attendance at the meeting. Likewise, FDA encourages you at the beginning of your statement to advise the committee if you do not have any such financial relationships. If you choose not to address this issue of financial relationships at the beginning of your statement, it will not preclude you from speaking. Dr. Lewis.
The FDA and this panel place great importance on this open public hearing process in order to adequately allow those who are speaking to fully address their complaints and shortcomings of the system. The insights and comments provided can help the agency and this panel in their consideration of the issues before them. That said, in many instances and for many topics, we know that there are a wide variety of opinions, often strongly held. One of the goals today is for this open hearing to be conducted in a fair and open way where every participant is listened to carefully and the panel anxiously is looking to hear from you and hear your views. And we wish everyone to be treated with dignity, courtesy, and respect. People will speak only when recognized by the chairman, and it's important that we maintain a strict limitation on the 3 minutes because we have 22 people signed up for 1 hour. And so to be fair and to give an opportunity for equal presentation time to the later participants, it's essential for everyone to limit themselves to their 3 minutes. We ask each each presenter to speak clearly into the microphone, and we will provide an accurate transcription of the meeting. Please identify yourself and your association clearly. If the speaker goes beyond 3.5 minutes, we will generally shut off the microphone in order to move to the next person. We also note that in order to be efficient, we ask that the speaker, when one person is speaking, the next speaker please position themselves nearby so that they can immediately begin their presentation on completion of the first speaker's comments. The first speaker today is Dr. William Adams from the Force Organization. Would you step to the microphone and begin your presentation?
Thank you. Good morning. I'm William P. Adams, Jr., a board-certified plastic surgeon and education commissioner of the Aesthetic Society, associate professor of plastic surgery at UT Southwestern Medical Center in Dallas, and chief medical officer of the Plastic Surgery Channel. I have no other financial disclosures for this presentation. Education and training of surgeons is a primary function of the Aesthetic Society, and since breast implant-associated ALCL was first recognized, the Aesthetic Society has been educating our members through clinical education and online accessible treatment guidelines and FAQs. Importantly, current data in epidemiology on ALCL has demonstrated at least 8 instances of case clusters and geographic distributions that indicate an infectious trigger or cause. Furthermore, this is an implant surface area issue, currently only occurring in patients with a history of textured devices and more commonly in larger surface area textured implants, providing an environment for exponentially higher bacterial implantation and sequestration. A similar bacterial-mediated adverse event pathway has been confirmed for the most common risk of breast implants called capsular contracture. Over the past 20 years, we've learned that surgical technique is critical, and I've spent much of my career researching and educating surgeons on techniques to reduce the bacterial load around implants during surgery. Techniques including the 14-point plan have reduced documented risk of capsular contracture from 50% 30 years ago to less than 1% in the past 5 years. We are confident that these bacterial load reducing best practice techniques will have similar risk reduction of ALCL for patients. Clinical evidence for this risk reduction in ALCL includes a study published in 2017 that you see here by 8 global surgeons using the same 14-point plan at the time of surgery in 42,000 macrotextured implants. The expected number of ALCL cases was 14, yet the actual number of cases in this study was 0. And finally, with regard to joint patient and physician education, working with advocates Jamie Cook and Terry McGregor, the Aesthetic Society and the Plastic Surgery Channel has featured ongoing collaborative educational dialogue between patients and surgeons. We have produced 2 separate programs to date. The first, a roundtable discussion including 3 ALCL patient leaders to create awareness and education on ALCL, and a second in-depth PSC deep dive program that was just premiered last week, focusing on roundtable education on key BII issues, best informed consent and communication practices for surgeons and patients. The feedback has been fantastic, and we intend to continue these patient-physician educational programs, and the main connected parties are currently working to set up a collaborative community per FDA guidelines. Thank you all for your time today.
Christina Avila.
Hello, my name is Christina Avila. I've traveled from San Jose, California by my own accord to speak before you today. Thank you for hearing me. When I was diagnosed with stage 3 breast cancer at age 38, as I joyfully raised a long-awaited 2-year-old, I put all my faith and trust in my doctors and went down the path laid before me. In a time of intense shock and vulnerability, many other survivors like me feel they were pushed down a path where they were assured their implants were safe, but told little to nothing about their many risks. Instead, they were often told that they were too young not to get implants, or that they would be left deformed, depressed, with low self-esteem, not feeling whole, complete, and the list goes on. Many felt they were not presented another option, and sadly, I have heard too many say, "I thought we had to do it." I will speak to you on what we should have been informed of, but we're not. Patients should be informed that the standard practice of radiating either expanders or implants is contraindicated by the manufacturers. And now I've read too many cases of fellow survivors who were radiated with silicone above their lungs, receiving new diagnoses of small cell lung cancer. Could I be next? We should be told expanders are not to be left in for longer than 6 months. Patients should know that if radiation is part of their treatment, they will almost always develop capsular contracture and possibly have issues with any incision made to that area healing. We should be told that beginning reconstruction at the start of our treatment often leads to complications that cause delays in our cancer treatment. This is not only compromises our health, but also our chances of survival. We should be told that a successful outcome will require multiple surgeries in just a few years' time during and following our treatment, and that each of these additional surgeries may trigger PTSD. We need to be informed that we will be left with a concavity if our implants are ever removed. Over and over, we are told there are no studies that show implants cause health problems, but rarely, if ever, told there are no valid, unbiased studies. How many survivors progress to stage 4 after getting implants? Women like me, who would rather be alive than have something that looks like boobs, need to know these numbers. I am sickened that during the 11-year ban, silicone implants were only allowed to be placed in one population, the most vulnerable one, breast cancer patients. Sorry, is my time up? People are clapping, but my time's still going. Breast cancer patients. Why were those of us who just finished fighting for our lives the only ones who could still be implanted with devices deemed unsafe for everyone else? All women deserve to be fully informed on what I have shared today. They deserve to know their risks. They deserve true informed consent. Since learning about breast implant illness, I have met thousands who never would have gotten implants had they received the proper informed consent. So many of them say it was their breast implants that caused sickness and suffering that far exceeded their cancer treatment, including chemotherapy and radiation. This speaks volumes. My name is Christina Avila. Please know that when you hear my voice, you are hearing the voice of tens upon tens of thousands of women. Thank you for hearing us.
Thank you. Dr. Anu Bajaj.
I'm a board-certified plastic surgeon who performs both cosmetic and reconstructive breast surgery in Oklahoma City. And I have had breast implants since 2003. While I am a plastic surgeon, I have never been an advocate for breast implants. Rather, I come as an advocate for my patients and for patient choice. My father is also a plastic surgeon who has been in practice since 1972. His experience in the 90s led him to distrust breast implants and their safety. During the past 20 years, I've also observed my own share of adverse consequences of implants, which have included rupture, infection, and capsular contracture. At times, as a young surgeon, I had thought, why would anybody want breast implants? And then I chose to get breast implants. I chose to get implants because I had felt self-conscious about my lack of breast development. I was tired of wearing padded bras and having clothing that did not fit. Once, as a woman in my 30s, after having gone for a run, I was told that I looked like an 11-year-old boy. So I got breast implants, and I have never regretted this decision, and I feel very confident and happy. Both my cosmetic and reconstructive patients have similarly told me that they are happy with their implants and do not regret their choices. Their comments have included how much they like their breasts or how much better they feel, and they never realized it would affect them so much. Numerous studies and my personal experience and my own patients have shown me that they do have a high satisfaction rate and can benefit your quality of life and self-esteem. My sisters also have had breast implants and have had very different experiences. One sister switched from silicone to saline because she was concerned about her health as well as the risk of silent rupture. The other sister had her implants removed because her body had changed. Every surgical procedure, including the placement of breast implants, has risks and benefits. Some patients will benefit and others may not. Like my sisters and myself, implants aren't for everyone. Our job as physicians is to listen to our patients, educate them about risks and benefits, and help them make the decisions that will be best for them. Our patients are capable of understanding these complications and risks, and each individual will need to make the choice that best suits her values. However, we need the data and information to provide our patients with the best and most up-to-date information available. We also need to educate our patients about the importance of annual follow-up with their plastic surgeons so that we can monitor for these adverse events. Rather than taking away choices from women, we should arm them with information so that they can make the right decision for themselves. Thank you.
Thank you very much for your comments. Dr. Bradley Calabrese.
Good morning, and thank you for allowing me to present to the panel. My name is Dr. Brad Calabrese. I'm a plastic surgeon board certified in Louisville, Kentucky over the last 22 years. I'm also a clinical professor of surgery at the University of Louisville and at the University of Kentucky. So I've been highly involved in education of plastic surgery residents and actually initiated a breast fellowship within my practice. I also publish and lecture extensively on the subject of breast surgery and probably most significantly on the issues related to breast implants, and I have no financial disclosures. As a member of the Aesthetic Society and as the chair of the BIA-ALCL task force over the last year, and after extensive review of the current world literature, our task force put together a large amount of material to physicians and patients, which are educational materials to help them. We also include a semi-annual advisory update that we do in conjunction with the ASPS. Additionally, in January 2018, in the issue of Aesthetic Surgery Journal, I published an article called The Long-Term Safety of Smooth and Textured Silicone Breast Implants. This article reviewed the data from all 5 core FDA breast implant clinical trials, in which all demonstrated long-term safety of smooth and textured implants in those studies. The limitations of many of these clinical trials is that struggle to meet the levels the FDA required for patient follow-up. In my experience, patients who are doing well often just don't want to come back for follow-up, and this can be a real challenge that we all face, but we desperately need this information. To improve follow-up in future clinical trials, our task force has recommended the use of technologies like maybe mobile apps and digital health to collect and analyze data to improve patient follow-up. Having placed over 15,000 breast implants, I've observed there's no one perfect implant choice. Smooth and textured, shaped and round implants each provide benefit to address challenging anatomical issues in both aesthetic and reconstructive breast surgery patients, and the implant choice must be balanced against the risks associated with each of these. Furthermore, I occasionally use textured implants. I use evidence-based medicine for that, and the data has demonstrated that bacteria as the probable cause of ALCL. So by using specific surgical techniques to reduce bacteria, I can reduce the risk of ACL to my textured implant patients, as Dr. Adams had mentioned. We agree it is critical to have innovative methods to facilitate better and more complete ongoing data collection of each type of breast implant for the lifetime of that implant. Our discussion and decision-making with our patients should always be based on good data-driven science and a complete consent process, which is critically important. I want you to know from the Aesthetic Society that we are listening to you, to Ms. Cook, to the women of the world, to the FDA, and we hear you. We are working tirelessly to understand more, provide more information, and promote research into all issues related to breast implants. We are committed to providing the highest level of patient safety, but also sharing this information with our patients and the public in a timely and unbiased manner. Thank you for listening.
Thank you. Dr. Lori Casas.
I got a letter to speak tomorrow in the PM session, so I'm not sure why I'm listed in this session.
All right. If you don't wish to speak, then
I'd like to speak, but I wasn't prepared to speak today.
Fine.
Can I speak tomorrow?
Thank you.
Thank you.
Ms. Jennifer Cook.
Hello, my name is Jennifer Cook, and I'm from Georgia. And here is a photo of me, my husband, and 4-year-old son on vacation days before my diagnosis of BIA-ALCL in 2017. As most of you know, the reports linking ALCL and breast implants began in the 1990s. In 2008, JAMA published an article recognizing that link. In 2010, a panel of experts looked at this long history and documented their agreement that the established scientific evidence is that a positive association does exist between breast implants and developing ALCL. But sadly, in the latter half of that same year, my plastic surgeon and the manufacturer communicated to me the exact opposite. Here is what my consent form said. There is presently no established scientific evidence that links either silicone or saline breast implants with cancer. I was given that informed consent because I was part of a study for an implant that was not yet FDA approved. Because I wasn't followed, because I had a revision surgery shortly thereafter, I have concerns that my complications were never documented. Years went by after my surgery, and don't you think my surgeon or the implant manufacturer should have made sure that I was directly aware that there was established evidence linking implants to cancer? But instead, I remained in the dark. And do you know how I eventually learned the truth? I learned it randomly from middle school students in an inner city school where I taught. The middle school students had written a play that made reference to media reports of implants causing cancer. Of course, I was shocked because I had been told just the opposite, and so I thought I was going to need to reprimand the students for making false, reckless statements. But before I did that, I Googled it, and that's when I learned the horrifying truth. I read a lot about BIA-ALCL, and shortly thereafter, I started to recognize that I actually did have symptoms of the disease, and I went to the doctor. Even though I was informed, none of the doctors that I saw were, including radiologists and breast surgeons. And so I was unable to recognize and get a diagnosis until actually a year later. And by that time, I had developed masses around my implant, and as a result, I had to have targeted chemotherapy as well as surgery. I was blindsided. I was deceived. I don't want anyone else to go through what I'm having to go through. One way to stop it is with mandatory, standardized, informed consent. Patients should not have to rely on their plastic surgeon, who may fail to stay up to date or may want to actually hide the facts. In recognition of the FDA's desire for the patient perspective, I sent a document to Mr. Garcia suggesting what I think should be in part of a standardized informed consent on BIA-ALCL. Everything in that document I believe to be true, and patients have the right to know it. Thank you.
Thank you for your comments. Ms. Jamie Cook.
Yeah, I think she's
All right, we'll move to the next. Ms. Dawn Chris.
Good morning. My name is Dawn Chris.
Turn the microphone on, please.
Oh, sorry. Good morning. My name is Dawn Chris, and I am from Alberta, Canada. And I have traveled here at my own expense. I received my textured Allergan implants in 2008 when I was 38 years old, and I was not warned of cancer or any type of disease. For 6 years, I was healthy and working. Then in 2014, I experienced intestinal issues, chronic fatigue, unexplained rashes, itching, and massive hair loss. After months of suffering, my body shut down, and I was hospitalized for blood loss and severe ulcerative colitis and autoimmune disease. In 2017, my left breast swelled up twice its size. My physician referred me for an ultrasound-guided needle aspiration to test for lymphoma and an MRI to look for rupture. Both results were negative. Despite my negative tests, I decided to remove my textured implants and replace them with smooth. In December of 2017, I had my first explant surgery, and it was determined that I had double capsules. The left inside capsule and implant surface tested positive for BIA-ALCL. 5 weeks later, I had a second surgery to remove the outside capsules and the new implants. Since my explant last January, all of my autoimmune symptoms have subsided. In the last year, I have had only one major flare-up in which it took mere weeks to recover instead of months. New patients need to know the risks of breast implants. The directions for use are given to plastic surgeons, and it lists numerous concerns, such as autoimmune issues, gel movement without rupture, and depression. This information is given to plastic surgeons, but not to the patient. Therefore, the patient cannot make a well-informed decision. Transparent, informed consent with a 2-paged surgeon-patient checklist and a black box warning should be a priority for all new patients. Please understand that not all women have obvious symptoms of this cancer, and some of them don't know about the disease until it is too late. False negatives from fluid collection is a common occurrence that cannot be ignored, and testing the capsular tissue after explant can no longer be the only acceptable way to diagnosis. The long-term safety of all breast implants needs to be investigated. This should include BIA-ALCL as well as the autoimmune symptoms typical of breast implant illness. While all breast implants can cause an immune response, textured have now been proven to cause this man-made cancer. Please take textured implants off the market. Continue studies through non-biased organizations, obtain accurate data from our current patient population, and include finding a more accurate way for testing and diagnosis that does not leave a patient at risk. We need to be able to work together within our healthcare systems to make sure that no one is denied testing or treatment because of their financial status, regardless if breast implants were an elective choice or not. Cancer is a hard reality for many of us to deal with. It affects not only our bodies, but our minds, our relationships, our working ability, and our own sense of security. For even the strongest believers, it takes away hope. Cancer was not a choice, and we sure as heck didn't elect to get it. Thank you.
Thank you. Ms. Nicole Garuda.
Thank you for the opportunity to speak. My name is Nicole Deruda. In 2005, I got Mentor silicone cohesive gel breast implants. I was perfectly healthy before breast implants, and in the first couple years with implants, very marked symptoms appeared. And by 5 years, my declining health was so bad, I had to leave my 25-year career. I'm not going to list all the symptoms because you're going to hear from many women about their systemic symptoms, and our stories are mostly identical. Suffice it to say, I had serious autoimmune symptoms and diseases, endocrine gland damage, and kidney damage. I, along with multitudes of other women, feel duped into believing breast implants are safe by plastic surgeons and manufacturers of implants. After experiencing breast implant illness and researching, I found that silicone is not safe or biologically inert, as described by my plastic surgeon, but rather it is made of approximately an array of toxic chemicals and heavy metals that leak from early on and interact with our body glands, organs, and immune system, causing profound illness. After experiencing this illness firsthand, I realized that 4 generations of women and their families have been harmed over several decades, and due to the current trend of breast implants, there would be many, many more sick women. I felt a deep responsibility to do something, and so in February 2013, I published a website called healingbreastimplantillness.com. Quickly, this website turned into a forum, which is now 70,000, because my hunch was correct. There are multitudes of women that are profoundly ill from their implants. Several hundreds of women arrive each day to our forum with the same story of symptoms, the same loss of health. We have all been repeatedly told our breast implants were safe or are safe, and our symptoms are not from our implants by both plastic surgeons and by family doctors who are misinformed. All of this illness and suffering could have been avoided if we had just been properly informed about the toxic chemicals and heavy metals of silicone and their real-world effects in our body, and how breast implants leak much earlier than anyone expects and documented in your own data. I cannot emphasize this enough. The crux of the issue is proper informed consent about the real failure rates of breast implants, the real-world effects of toxic chemicals and heavy metals of silicone, and the real health consequences of these ingredients in our body is not occurring. If women knew up front of the toxic chemicals and heavy metals in silicone and the real failure rates, they would never buy breast implants, and this issue would disappear. If doctors knew the truth, they would not be misdiagnosing their patients. Proper informed consent is the only moral, ethical, and common sense solution to decades of profound harm to women. FDA, stop the manufacturers from hiding the truth that should be available to anyone considering breast implants. It's no longer possible for you or anyone to minimize breast implant illness. We are not going away. These issues are not going away. Please do the right thing by enforcing proper informed consent in respect to saline and silicone breast implants. Thank you.
Thank you. Ms. Holly Davis.
Yes. Hello, my name is Holly Davis. Can you hear me, everybody? Can you hear me?
Can you move a little closer to the microphone, please?
Closer?
Thank you. That's
All
excellent.
right, here we go. My name is Holly Davis. I'm from Charleston, South Carolina. I'm taking time from my work to be here for this momentous opportunity to stand here before this panel. Thank you very much for allowing this, especially as it regards breast implant illness, and I have not been paid to be here to speak today. I'm speaking to best practices for informed consent discussions between patients and clinicians. I believe it's been stated over and over here today that we do not feel that we have been effectively and appropriately informed. That consent does not exist. The pamphlets that some manufacturers are giving to the plastic surgeons aren't making it to us. We are told very briefly about the inherent risks to surgery, not to the implants. Let me just tell you, first, please, my ladies here with BIA-ALCL diagnosed, stand again, please. Some of you may be in line. I cannot have this not be seen by the manufacturers. Your numbers aren't equal to the people that are here today. How rare can this be? This is North America. This isn't the world right now. Ladies that are suffering from BII or any Asia, anything else, please stand. Don't ignore us. We are real, okay? I got implants in 2002. I had a prophylactic mastectomy. Ladies, if you want to sit, go ahead, but I actually think that it kind of is helping for them to see you continue to stand here. There are people here today that want to tell us that implants are awesome. I had a double mastectomy prophylactically. They found cancer in my left breast. I knew that it was a matter of when, not if. Damn it, if they didn't find it in the left breast at the time of I had my surgery. My surgeon I trusted, my team I trusted, Medical University of South Carolina. I was told in 2002 that they had the Mentor high-profile cohesive gel as part of a trial. Whoopee, lucky me, I could be in a trial and I get these. They're going to be awesome. And you know what? Before my expanders they were finished with it, I had capsular contracture so hard I was paralyzed in my right arm. I couldn't move my head and my breathing was so compromised that I had to have surgery immediately to remove it. There was no talk about, gee, we should try something else. Instead, the implant was put in. Symptom after symptom came after that. I thought I was aging badly. My memory became so concerning to me that I actually sought out neurologists at the Medical University of South Carolina. I asked specifically to start undergoing testing for Alzheimer's. I was told in the end that it was stress. Gee whiz. Who suffers stress? I had 2 young children. Part of the reason that I had
My colleague, Dr. Lara Gevgan, could not be here today. I am here to read her testimony. My name is Dr. Lara Devgan. I am a woman who cares about breast health. I am testifying today as a board-certified plastic surgeon, the mother of 6 young children, and chief medical officer of Real Self. Real Self is the world's leading online destination for women interested in breast implants, where nearly 100 million people a year go to learn about plastic surgery procedures and candidly review their experiences. Over 10 million people in the world have breast implants. 300,000 women get breast implants every year in the United States, and about 1 in 20 adult American women have breast implants. In 2018 alone, people visited RealSelf 10,969,011 times to research breast implants. Through RealSelf, we have a tremendous amount of data to support the safety and efficacy of breast implants. On a population level, women are very happy and satisfied with their breast implants. Over 55,000 women have reviewed breast implants on RealSelf, with nearly 97% of them saying that they are worth it. What we do is medicine, not magic, and life does not promise us perfection. However, this data echoes my experience in my medical practice, where I have personally placed hundreds of breast implants for cosmetic reasons and cancer reconstruction in New York City. Placement of breast implants is a real medical procedure, meaning it has risks, benefits, alternatives, and indications, just like all medical procedures. Further, science is always evolving and maturing, and the more data that we collect, the more we can understand and improve our processes over time. Over 84,000 questions about breast implants have been asked on RealSelf, with more than 619,000 answers by board-certified plastic surgeons. I want the FDA to know that we care about our patients, and we are committed to helping them. My message to those considering breast implants is that we, as board-certified plastic surgeons, are extremely committed to patient safety, information gathering, and the well-being of the people who put their bodies and lives in our hands. While I cannot predict the future, I can confidently say I would feel comfortable having breast implants myself or recommending them to my loved ones who desire them. Thank you.
Thank you. Ms. Terry Diaz.
Hi, my name is Terry Diaz. I am a breast implant illness survivor. Thank you for the chance to tell my story. At 38 years old, I was living the best life. I had a thriving business, I was in shape, I ate right, and I felt and looked my best. The only thing missing were the breasts I had before nursing my 3 beautiful boys. So in 2006, I opted to have breast implants placed. My plastic surgeon chose Mentor high-profile saline implants. He told me that the implants were completely safe and that they were lifetime devices. He emphasized that they were the safe saline implants, and the only real complication would be rupture if I was to have a high-impact injury to my chest. Within months of implant surgery, I started having symptoms such as migraines and unexplained weight gain, despite my healthy lifestyle. I started then having flu-like symptoms that I could not relieve. The symptoms kept accumulating. I was referred to countless doctors of various specialties. By the 6-year post-implant, I was diagnosed with multiple autoimmune illnesses. I was completely bedridden, waiting to die. I couldn't even walk up a flight of stairs. Not one of the medical professionals that examined me considered my implants as the cause of my illnesses. Luckily, my lifelong friend, a science researcher, suggested that it could be my implants. I started researching and found a website and Facebook group that had at the time 3,000 members, all who had some variation of my symptoms. It was from these women, not one of the medical, It was from these women, not the doctors, not the manufacturers, or the FDA, that I was educated on this disease and how to do explant surgery. From seeing the desperation of women looking for answers for their illnesses, I decided to facilitate a local illness group. That was almost 3 years ago. My group, Breast Implant Illness Florida Support Group, grows by the hundreds every month. Not only am I telling my story, but I'm here representing them. I am inboxed daily by hopeless women, many who've lost thriving careers with no finances and unable to afford health care. This health crisis affects all of us and has been going on for decades. The other multiple groups on social media that I'm involved with, they grow by the hundreds daily, totaling nearly 150,000 women. Breast implant illness has cost me everything. I had to close my thriving business. I'm in the process of being accepted into a Chapter 13 and home loan modification, but I still may lose my home. I can no longer afford health insurance and cannot afford medical care. Today, I am no longer bedridden, and I'm about 85% better. The only medical procedure I had was the explantation of my implants. I lost 10 years of my life due to safe implants. My symptoms are up there. Those are the ones that are gone since I've explanted. My plea to you is this: informed consent. Provide a black box warning on all breast implants mandatory. Patient information booklet, doctor-patient checklist, chemical data transparency, and mandatory testing for BIA-ALCL for all women explanting. I appreciate your time. I know you are hearing us. Thank you.
Thank you. Dr. Gloria Duda.
Good morning. My name is Gloria Duda, and I am a board-certified plastic surgeon and a member of the Aesthetic Society. I've been in private practice in McLean, Virginia since 1992, and I have no conflicts of interest and no financial interest in industry. I spoke during the General and Plastic Surgery Devices Advisory Meeting in 2015 and 2016.
The State of Israel took control of the Golan Heights in 1967 to safeguard its security from external threats. Today, aggressive action by Iran and terrorist groups in southern Syria, including Hezbollah, continue to make the Golan Heights a potential launching ground for attacks against Israel, very violent attacks. Any possible future peace agreement must account for Israel's
after mastectomy. When asked if they would make the same decision again, the overwhelming response has been yes. Patients have returned to my practice for secondary breast procedures regarding capsular contracture, implant rupture, or cosmetic changes due to the aging changes of the breast. In discussing their surgical options, removal of their implants without replacement is discussed, and 90% of our patients have elected to have their implants replanted. None of my previous 6,000 breast implant patients have returned requesting removal of asymptomatic breast implants, and none of my patients have complained of breast implant illness. I have seen new patients requesting removal of their implants for various reasons, including undiagnosed systemic symptoms. We counsel them that their implants can be removed, however, their symptoms may not be related to the breast implants. I do have one patient who was diagnosed with breast implant-associated anaplastic large cell lymphoma 5 years after her textured implant was placed. She was appropriately treated, and she remains free of disease now 3 years later. Like many, my patients have not been compliant with the MRI follow-ups for detection of asymptomatic rupture, and the reasons that they include are the expense of the MRI, radiation exposure, false positive readings that lead to unnecessary surgeries, and there remains a need for a less invasive and in-office procedure to assess the implant integrity. As plastic surgeons, we are patient advocates. We're committed to our patients with respect to education, safety, and satisfaction. Patients have easy access to information through the media, and however, this information is not always based on credible data and that can also be sensationalized. It would be beneficial for all of our patients if the media chose to also include positive information and the overwhelming satisfaction regarding breast implants. Until objective data is collected on breast implant illness and breast implant-associated anaplastic large cell lymphoma, and definitive decisions can be made, I'm here to advocate the continuation of a woman's right to have an informed choice regarding her breast implants. Thank you. I'm appreciative of the opportunity to be part of this important assessment. Thank you.
Thank you. Dr. Claire Duggal.
Good morning. My name is Claire Dougal, and I am a board-certified plastic surgeon in private practice. My practice is focused on breast surgery, and I place breast implants for both cosmetic and reconstructive purposes. With access to all of the information and studies currently published relating to breast implant safety, I choose to place all available types of implants, including saline, smooth silicone gel, and a limited number of textured silicone gel implants. I personally have textured implants placed for cosmetic reasons, and I can attest firsthand to the immense benefit breast implants can have on body image and quality of life for many women. I have not personally taken care of any patients with BIA-ALCL. I do discuss the growing body of evidence related to this condition with every patient. It is definitely a factor when deciding which type of implant to place for each individual patient. If a patient has an anatomic or technical reason why a textured implant might be a better choice for them, including a history of implant malposition, a history of capsular contracture, the desire to have implants placed on top of the muscle, or the desire to have an anatomically shaped implant, I have a long discussion regarding the risk of ALCL, the signs and symptoms, and the treatment plan. I explain to patients that implants are intended to make them feel more comfortable with their body, not create additional anxiety, and together we make the decision if a textured device is appropriate for them. I also occasionally see patients with a varied constellation of symptoms which are referred to as breast implant illness. These women most often have no palpable scar tissue, no evidence of implant rupture, no lab abnormality, and a thin filmy capsule which can be difficult, if not impossible to completely remove, making the diagnosis difficult and frustrating for all involved. By the time I see these patients, they have generally decided their implants are the problem and desire removal, and I do not ever hesitate to remove implants for anyone that would like them out. I have found that some patients experience an improvement in their symptoms after implant removal, and some do not, and we discuss this prior to explantation. I practice longitudinal care and offer lifetime evaluations to my breast implant patients. The overwhelming majority are happy with their implants and experience improved quality of life after surgery. I feel responsible as a surgeon for having the most up-to-date information about implant safety in order to be able to appropriately counsel patients. And I believe that the preoperative discussion with patients is of paramount importance in helping them to make an informed decision regarding their bodies. Thank you very much.
Thank you. Ms. Julie Elliott.
Good morning, ladies and gentlemen of the panel. Please bear with me as my first language is French. My name is Julie Elliott and I'm from Quebec, Canada. I had Mentor Smooth Cohesive Gel implants for 10 years. When I decided to get breast implants, I knew every surgery has its risks and that implants could rupture or cause contractures. But my surgeon said that the newest generation of implants were impossible to rupture and the cohesive gel would never leak. Implants transformed me from an athlete with a full-time job to a full-time patient. 3 weeks after getting my implants, I noticed the first changes in my health. I experienced extreme exhaustion, rapid weight gain, paralyzing brain fog, and intolerance to sound and heat. 9 months after getting my implants, I was diagnosed with Hashimoto disease. Later on, I experienced muscle pain so severe I had to stop exercising. My hair was falling out, and I was always thirsty. I was also diagnosed with asthma. I then developed numerous food allergies. My throat was closing after each bite, and my gastrointestinal issues became so severe that I had to stop working. In 2016, I read about breast implant illness. I had been searching for the cause of my health problems for 10 years, and it was right in front of me. I had 2 polymer bags inside of me. I had my implants removed in January 2018. A month after my surgery, I was sent my implants and capsule to be analyzed by Dr. Pierre Blais in Ottawa. My capsules were 100 times thicker than what he usually sees and were covered with granulomas. But the most shocking was the fact that one of my implants had a micro-rupture of long-standing origin that had leaked silicone oil into my body for years. After my explant surgery, several of my long-term symptoms disappeared almost immediately. Today marks my 14 months since my implant surgery. While some of my symptoms still remain, I am healthier than I've been in years. My implants greatly compromise my health, and it may take years to recover. I decided to create the first French-Canadian support group for women affected with breast implants. The group immediately got to over 800 members and growing every day, and these members are actually 800 patients. I stand in front of you because women are literally dying from their implants, and no one believes them. We need more long-term research studies on the complication from breast implants that focus on symptoms and not just diagnosis. I stand in front of you because I see women fighting every day to get proper testing for BIA-ALCL. Healthcare providers need awareness on the latest developments about diagnosis, pathology, and treatments for this cancer. I stand in front of you because every day I see women who have no clue what kind of implants they have inside their bodies. We need national registries that tracks all health complications and not just reoperations. I stand before you because I know the FDA can lead the way and be the role model we need. This meeting is FDA's opportunity to listen to what patients are saying about their experiences with implants so that public health agencies make decisions that will help shape the future health of millions of women around the globe. Thank you for this opportunity.
Thank you very much. Ms. Terry McGregor.
Good morning. My name is Terry McGregor. I traveled from Ontario, Canada at my own expense. 4 years ago, I was diagnosed with ALCL. From breast implants, they were 6 years old. My diagnosis was stage 4. The joy of life was cut short by a profit-driven man-made cancer. Life as I knew it ceased to exist. Clinic appointments, tests, exams, chemotherapy, debilitating side effects, and excruciating procedures drained my reserves. I failed 6 rounds of CHOP. I failed relapse chemotherapy, and my prognosis changed to terminal with 4 to 6 months to live. I received brentuximab under clinical trial through our national healthcare system in Canada, and after 4 rounds, I was NED. No evidence of disease. I underwent a stem cell transplant as my best hope for long-term survival. I've recently been given my second cancer diagnosis, a complication from transplant. Being a vanguard in round 2 for a club I never wanted to join is unbelievable. Our patients are facing reoccurrence and complications from this cancer. I have never been asked to participate in a study for BIA-ALCL. In my deepest thoughts and most private moments, I ask myself if I can endure a repeat of the excruciating effects of treatment. Well, I did my best to wear a brave face as a mom, a wife, and a daughter. I watched my loved ones struggle as I became a typical cancer patient, and they were helpless. My health declined. The isolation, betrayal, loneliness of our cancer is compounded by the dismissive public relations campaign by industry. While patients and clinicians called out on the emerging evidence, the industry stayed silent. When our existence could no longer be denied, we were merely portrayed as an anomaly. Our disease status was to be reported to the FDA by the manufacturers who created our cancer. Allergan took 19 months to send the follow-up from my reporting physician. With FDA annual reporting, Allergan was able to avoid confirming my case for 3 years. Underreporting and undiagnosed are common and unacceptable. I've collaborated with Dr. Peter Lennox of the CSBS in Canada to assist collecting our 28 Canadian cases. The 5 cases reported by the manufacturers to Health Canada did not include me. Our advocacy team helps thousands of women every day with awareness and education. We want clinicians to be the experts, not patients. The presence of an implant has become a detriment to oncology investigation. We patient advocates request a seat at the table. We ask surgeons to contact their past patients with or without FDA recommendation. Lastly, please evoke your full authority to withdraw all textured implants and expanders from the market and end the suffering of tomorrow's families. Thank you.
Thank you. Ms. Daniela Valores.
Hi, my name is Danielle Valores. I'm a physician assistant, and I've worked in the medical device research industry for over 20 years. I love innovation. I'm also a BII survivor. Thus far, breast implants have cost me over 3 years of my life and over $100,000. FDA, I'm asking for you to hold the device manufacturers accountable to conduct the appropriate long-term safety studies and ask the appropriate questions. 2, initiate a patient checklist providing full disclosure on the surgical and biomedical risk of breast implants. 3, a declaration from you, the FDA, recognizing that breast implant illness is real so those affected can get the support they need. My breast augmentation was in December 2015. I was 48 years old and I lost 40 pounds. I was in the best shape of my life and I wanted to look as good as I felt. I met with my plastic surgeon and he recommended breast augmentation, saying it would be a perfect fit for me and the only real risk would be that of anesthesia. There was no mention of the associated risks for those of us with a history of autoimmune disease. Fast forward almost 2 years, I was in and out of hospitals and doctor's offices with migraines, swelling, muscle pain, fatigue, common symptoms that we BII people have. I kept looking for answers and I soon realized I needed to remove my implants. It took multiple visits and over a year before I can convince a plastic surgeon that the implants were a problem. When my lymph nodes started to swell, the doctor finally became concerned and agreed to explant. I became extremely ill, and surgery seemed unwise until I got better. I never got better, but I knew I needed to explant, so I did October 2017. Immediately after the explant, the swelling, migraines, joint pain were all gone. My inflammation markers and my heavy metal levels also went down. Please note, my implants did not rupture. There's a slide to go with my presentation, and it's not here. Is there? There we go. And one more. This is a picture of me, and on the left you can see a thermography with implants, and depicting the red and the yellow is inflammation. 2 weeks post-explant, I wanted to see if the inflammation was still present, and you can see it is greatly diminished. I have worked, I was told that these could not cause any physiological issues, and obviously that's not true. I've worked on many Class 3 clinical trials, and it is mind-blowing that the FDA did not require better safety data and did not hold the companies accountable. When I look through the MAUD evidence online, through February 2019, there have been over 51,000 adverse events, over 43,000 were injury-related, and 116 were death-related regarding breast implants. There are life-saving devices that are worth the risk of serious harm. Breast implants are not one of them. The FDA is a public health agency. The taxpayers should be your most important customers, not the device companies. Please require that the manufacturers boldly display potential risks for cancer and autoimmune issues and hold them accountable. We need more longitudinal studies on how to best treat implant victims so they can regain their health. The first and most important step for the FDA is to acknowledge that breast implant illness is real. And until that happens, thousands more will be harmed. Thank you.
Thank you. Mr. Stephen Teitelbaum. Not here. Dr. Mary Gingras.
My name is Dr. Mary Gingras. I'm a board-certified plastic surgeon. I've been in practice for 24 years. The majority of my practice is cosmetic breast surgery. I also have silicone breast implants, and I have no disclosures. I'm here at my own expense. My goal today is to inform the panel that the FDA's current recommendations for MRI for detection of silent rupture have not turned out to be clinically practical. A recent study by the Aesthetic Society found that less than half of members routinely order MRI for routine surveillance. The reasons given were cost, compliance, high false positive, and false negative results. Clinical data and real-life experience show that doctors aren't ordering and patients aren't getting these MRIs. Most of the time, the MRIs are ordered when rupture is highly suspected or when it may change the operative plan. On behalf of the Aesthetic Society, myself, and most importantly, my patients, I would like to suggest that high-resolution ultrasound, mammogram, and self-breast exam are more practical modalities for routine surveillance. I would like to recommend that the FDA recognize ultrasound surveillance starting at 10 years after implantation and then every 5 years thereafter. This is based on data that rupture rates for the newer 5th generation implants do not exceed 10% until after 10 years. This imaging demonstrates the ease of differentiating an intact implant on the left and a ruptured silicone implant on the right. This is a comfortable, fast procedure and can often be done right in a physician's office. This Sentinel publication, published in 2012, demonstrated the efficacy of ultrasound in monitoring patients and identifying rupture. A more recent follow-up study by the same authors has evaluated 700 breast implant patients. Patients were assessed with ultrasound preoperatively, and then results were confirmed intraoperatively. The sensitivity of the ultrasound was 98%, and the specificity 100%. Bottom line is that both doctors and patients need a more accessible method for surveillance. I propose that the FDA add high-resolution ultrasound combined with routine mammogram and self-breast exam and, of course, physician follow-up as an accepted modality because it is more practical, less costly, and maybe even more effective than MRI. Thank you for allowing me to speak.
Thank you very much. Dr. Fouad Nahai.
I'm Fouad Nahai. I'm a board-certified practicing academic plastic surgeon and the current editor-in-chief of Aesthetic Surgery Journal, ASJ, the flagship journal of the Aesthetic Society. The journal has the highest impact factor of any journal in its class, a circulation in the United States of approximately 4,000 and worldwide circulation of over 6,000. I have no financial disclosures. The goal of the journal is to advance the science, art, and safe practice of aesthetic surgery and cosmetic medicine through the publication of peer-reviewed, data-driven, evidence-based clinical and research studies. The FDA has called the meeting to address the data on the risk-benefit of breast implants. As the world's premier aesthetic journal, we have published many peer-reviewed studies on the 7 concerns of the FDA. In our current March 2019 issue, we published a supplement on BIA-ALCL containing the latest, most accurate information on the etiology, diagnosis, and treatment of the condition. The Aesthetic Journal has also published peer-reviewed information on systemic symptoms reported by patients with implants and has published on and has encouraged the establishment of breast implant registries worldwide. The Aesthetic Journal consistently publishes works on detection of silent implant rupture with MRI, and as we just saw, the alternative ultrasound technologies. We publish featured articles on the application of surgical mesh in breast surgery, best practices articles on breast implant surgery, as well as on informed consent. Informed consent, which always highlights the unique nature of this concern as new data and clinical findings surface. Lastly, the Aesthetic Surgery Journal is a source of peer-reviewed, patient-centric data following breast implant surgery. Our peer review system is double-blind and free from any conflict of interest. As editor, I have always maintained that the role of any scholarly publication is to publish opposing views and to encourage debate and discussion. Ongoing data collection on breast implants is critical, and I assure you that Aesthetic Surgery Journal will continue to publish peer-reviewed, data-driven scientific manuscripts with the goal to further our collective understanding of the risks and benefits of breast implants, and which will continue to empower plastic surgeons and their patients with high-quality information to ensure all care decisions are based on the best available evidence. Thank you for your time.
Thank you. That ends our public presentations, and I want to thank all of the speakers who presented their eloquent and very personal issues relative to breast implants. I believe that your comments and descriptions have been extraordinarily helpful to the panel in pointing to directions forward, and I thank you all for doing so. We will now break for lunch. Panel members, please do not discuss the meeting topic during lunch, either among yourselves or with the audience. We'll reconvene at exactly 1:10 and continue the afternoon session. Thank you.
So what would you like me to do? Just to come back tomorrow and...
Yeah, I could...